just by chance.
Welcome back after lunch, and thanks again for coming to our conference. This is a public panel on public health in the deregulatory age. And we have 4 panelists, and they have each done a lot of things, and I want to give them most of the time. So instead of reading their biographies, which are in the program, I'm just going to name them and mention their institution and then let them talk. And as you know, public health is a very broad, very diverse field, and they'll each be covering a different topic under it. So our first, I'll just mention them in order, and then I will let them take. Each one of them is going to talk no more than 15 minutes, and then we'll leave time for questions. So our first speaker is Dr. Paula Braveman from the director of the Center on Social Disparities in Health at the University of California, San Francisco. She will be followed by Professor George Rutherford, who is the vice chair of epidemiology and biostatistics in UCSF, University of California, San Francisco. Then Professor Jason Schwartz from Yale will speak from the Public Health Law School and the School of Medicine in Yale will speak. And finally, Professor Rob Schwartz from UC Hayes. And not related.
They never told you?
Sorry. Who's a professor of law here and also teaches at the University of New Mexico will speak. So that's our order, that's the plan, and let's get to it. Here you go. Here. On this.
Let's see, I'm going to put my water supply there. That's it. Well, it's a real pleasure to be here today. It's not such a great pleasure to speak right after lunch, but we'll hope we can keep your attention. Other panels are addressing. Well, you had a panel addressing the environment. Another panel will be addressing healthcare, and as Dorit mentioned, we're focusing on public health, and I want to focus particularly on making and supporting the point that that administration policies on and their effects on social programs, and by social programs I mean non-medical care programs, are very likely to harm health, particularly of vulnerable people, much more than the adverse effects on medical care, although we have adverse effects in both of those domains. And so one of the points I want to make is that this is not wishful thinking about the importance of social factors and their impact on health, that there have been tremendous advances in science in the last 20 years, and particularly advances in neuroscience, I think, that have put together an evidence base that tells us that social factors such as income, education, housing, conditions in neighborhoods, and chronic stress coming from any cause all strongly influence health, that those influences are probably greater than the influence of medical care, although I'm someone who stays away from the quantification of that such a percent of premature mortality to this and such a percent. That's precision is beyond where the knowledge is right now. And that we have, there's more that we don't know than we know, but we do know enough about biomedical pathways that explain the connections between social factors, such as the ones I've just mentioned, between social factors and health, to make this hypothesis very beyond plausible. And the other major point that I want to make is that I'll be talking about administration policies and sort of mixing together those that have already been enacted and those that are just proposed, but that they would very likely harm the health, particularly harm the health of disadvantaged groups directly, but both directly and indirectly by cutting social safety nets and other programs. So first, some background on this hypothesis. Why would I say that the effects on social programs are likely to have a bigger effect on health than effects on medical care. So here's just one tiny little piece of evidence that I think probably everyone in this room has seen this. It's been this way for over a couple of decades, but the US ranks very, very low on life expectancy. I was part of a study conducted by the then Institute of Medicine, now National Academy of Medicine, charged to look into were there particular health outcomes in which the US had the disadvantage and not others, and was it just in particular age groups? And what the panel concluded was that across the board, with very few exceptions, the US was at or near the bottom among other affluent countries, other affluent democracies, on almost all of the standard indicators of medical care, and that this applied across the age spectrum, except if you're 75 or older. And then the health of our 75 and older people compares favorably with that of people in other affluent countries, but beware of being under 75. This is a graphic that was created by a Scottish physician named Thomas McCune, published a book in the early 70s. And in it, he traced out the mortality, rates of mortality in England and Wales due to a range of different conditions. Why England and Wales? Those were the only countries that had mortality data going really far back, and he was able, with those, trace it back to the middle of the 19th century. And so I'm just going to show you one, but I'm going to tell you that the take-home message from all of the ones that he looked at is basically the same. So if you look, this traces out infant mortality rates in England and Wales, and you see during the latter half of the 19th century, it's a wavy baseline. It's basically stable. But then you see at the turn of the 20th century, you start to see this pretty dramatic decline. And it keeps declining and keeps declining at a pretty steady rate. And then you look at when was penicillin first available? It was around 1941. Sulfa drugs were available a few years before that. But basically use of antibiotics, we didn't have antibiotics around till around 1940 and later. When did neonatal intensive care units come into existence? Well, that wasn't until the 60s. And I think one would be hard put to name other modalities of medical care that would likely have an impact on infant mortality that were in place before, apart from supportive measures, that were in place before we had antibiotics and neonatal intensive care units. And the conclusion, this has been studied a whole lot and debated heatedly, and most public health experts agree that what explains that dramatic decline in mortality is not medical care, but it's improvements in living conditions. It's improvements in sanitation and clean water and nutrition, ventilation in working areas, ventilation in housing, better housing. And if we had time, I could show you lots of these. So now another little exhibit to illustrate the point, illustrate and argue the point. And this shows data on life expectancy at age 25. So keep that in mind, that this is not at birth, because I think most of the time we're used to seeing life expectancy at birth. This is at age 25, the number of years you could expect to live more, if you've reached age 25, separately for men and women. And in both cases, broken down according to family income expressed in percentages of the federal poverty level. And the bar on the far left for men and for women represents the poor, those under 100%, at or under 100% of federal poverty level. And the bar on the far right in each cluster, the green one, I have to check what, the colors aren't always the same. It represents the highest income group that we could look at, which were people with incomes at or over 4 times the federal poverty level. So not wealthy by any means, but probably solid middle class. And then the groups, you see the groups in between. And what you see here, both for men and for women, you certainly see a dramatic difference between the poor and the highest income group. But there's not just a threshold at one point. There's this stepwise gradient shape. And others have studied this in data from other countries. My group took a look at scores of health indicators to see if this applied very, very widely across health indicators in the US. And we found that generally for non-Latino whites and non-Latino blacks in the US, this was the dominant pattern. It's a whole other topic of discussion about Latinos. The reason that I'm making a big deal out of this gradient is that this is what we in medicine would call, this displays a dose-response relationship. And that's just one of many criteria that you need to support a causal inference. And I would say that the other criteria for causal inference are well met for the relationship between income and health. I also want to tell you that the patterns that we found looking at education instead of income, it was the same take-home message, not exactly the same, precisely the same detail, but the same conclusion. So one of the criteria for causal inference is that the hypothesis of the link, it needs to be plausible. It needs to be biologically plausible, needs to make sense, and the putative cause needs to come before the effect. So let's just think about something that it's probably obvious to most people, but I'm going to talk about it because these issues get debated, and I think it's important to put out there what the evidence tells us. So in every case, for the next few slides, I'm going to be talking about a lot of links. In each case, what I want you to know is that for each link, there is a body of evidence to support it. I am not saying that there is 100% consensus in the literature to support each one of the links that I'm going to be talking about, but I am saying that there is a critical mass of literature by respected scientists in respected journals that support these links. So I think not hard for most people to imagine how income shapes medical care. A healthy diet costs more than an unhealthy diet does. You have more options for physical activity, for leisure physical activity. If you have more money, you can afford to buy or rent a home in a neighborhood with healthy conditions, including safe and appealing places to exercise and without pollution. But you also can afford to buy services. That, I think, is not something that people think about a whole lot, is what it is that the ability to buy services can give in terms of promoting health. I think that thinking about the ability to buy services as a way to relieve stress, I think it's a very, very important piece of the puzzle. And then when families under stress, of course, we know that threatens family stability, which then becomes another source of stress, right? So there's generational effects here because the parents' income is going to shape the health of their offspring in paths that go partly through income and partly through education and then go through work. Neighborhoods can affect health in many, many ways, some of them obvious and some of them not so obvious. One of the not so obvious ways are the social networks and the social support that are available to you in some neighborhoods and not in others. Effects on kids, like what are the norms and the role models and the peer pressures like in a given neighborhood, can have a huge effect on health, some through health-related behaviors. Quality of schools, a very, very important way in which variations in neighborhood conditions that primarily adversely affect, that disproportionately affect people of color. The quality of schools being tied often to the wealth of the area because in this country, property taxes are a major way that schools are funded. And just want to make the point that because of racial segregation, Blacks and Latinos are tracked into poorer neighborhoods than whites, even at the same income. So it's not enough in a study to have just controlled for income. Education, I'm going to go quickly through this. There's a fair amount known, not everything that we need to know, but about how education can influence health. And I think the pathway that probably everybody in this room, and certainly anybody in training in a healthcare profession is aware of, is how educational attainment is tied to greater knowledge of health and health literacy and better problem-solving skills, and so there are better health-related behaviors, and those lead to better health. But that's not the only way in which the evidence tells us that education could influence health. And a major way is how educational attainment shapes work. I don't know if anybody in the room is from a background of fabulous family wealth. If there is, for those people, their future earnings are not particularly shaped by their educational attainment. But for the rest of us, the main thing shaping our income is the kind of work that we get, which is shaped by the quality and the quantity of the education that we get. So all of these pathways have been, there's a literature on them. And then finally, another set of pathways that are more psychosocial, and they're really fascinating, but we don't have time to talk about them. How could chronic stress, in many of these, I've been talking about stress as the mediator of the effects on health, and say we don't know enough, but we do know something, and enough to make the thesis that chronic stress harms health more than plausible. And it's, for example, this is just one pathway where we experience a stressor, one part of our brain sends a signal to another part of our brain, and then that other part of our brain sends a signal to our adrenal glands, and then our adrenal glands pump out cortisol. And if it's just an acute incident, it's probably not bad for us, but it's when your organs and your systems are being constantly bathed in cortisol over a prolonged period of time that it looks like there are very toxic effects on multiple organs and systems. So I think that there's this body of evidence now that they explain how our experiences, which are shaped by social factors, how they shape health across the life course. Neuroscience is very, very important. I think we know enough now to hypothesize that chronic stress is very likely a major contributor, not only to socioeconomic inequalities in health, but also to racial and ethnic inequalities in health. We know that childhood experiences shape adult health, and when we leave that out of the picture, what were the experiences in child, we're probably leaving out a major impact on health. Epigenetics, how our experiences can determine, the graphic way to think of it is that our experiences may install switches that can switch on or off whether a given gene is expressed. So if I have a very bad gene, but the regulation of it is that gene is not going to get expressed because that switch is off, then I'm not going to be harmed by that bad gene, and so forth for good genes. And this completely turns the sort of genes or destiny notion completely on its head. So I think that these are just some exhibits or examples, I think, to hopefully to stimulate your imagination. But there's a huge body of scientific evidence that tells us that social factors like income and like education and what they can buy, like housing and neighborhood conditions and chronic stress, that they strongly influence health, that it's probably more than the impact of medical care, that we know a bit about the pathways, the social pathways and the biological pathways, so that in the case, I know that the title of this conference was about deregulation, and there's obviously been deregulation in the environmental area that I'm sure was talked about this morning that fits that mold and that is likely to have massive effects on the health, particularly of vulnerable people. I'd say that the other effects on school integration and ways in which the Justice Department is permitting school districts to do redistricting that will prevent school integration, that because of education as a social factor with profound influences on health, that's an example of a deregulation under this administration that can be expected to have very, very serious health effects, but particularly on people of color, and the school privatization, which ultimately leads to a starvation of funds for public schools, are all examples that I put in the deregulation column. But I think related to, maybe it's not the letter of the concept of deregulation, but in the spirit in which I think this conference was pulled together, that I've chosen to interpret defunding, that various moves to defund social programs under that as related to that rubric. And I don't think, it's a moving target every day. We see something different, right? But the constants are the attempts to defund education, social safety net policies, affordable housing, and I haven't even mentioned the impact on Medicaid, the Children's Health Insurance Program, and Medicare that are in both that would be consequences of both the House and the Senate's version of the tax bill. But again, those are in the area of medical care, and it's very, very serious, and there'll be a lot of suffering if that happens. But I think in the end, the suffering will be greater with the impacts on social programs, but the effects on health may not be seen for decades. And this is something that's very tricky to keep in mind when you are thinking of things, because the children are going to be more susceptible to the effects of the cuts. And given the physiology of stress, or given the way a lot of these conditions express themselves, it's not until children are in middle age often that the chronic diseases are starting to manifest that could be linked to experiences in childhood. So just looking cross-sectionally is not going to be enough to assess the effects. Thank you.
Sorry.
The Batman there.
Oh, yeah.
No, it's got to go back. There we go. So it's a pleasure to be here. Everybody in my family are lawyers besides me. I have a niece who went here, so it's I always like to rub it in their face. So I always ask, my favorite question is always, what's the 10th Amendment to the Constitution? And the answer is it's the one that says if it's not in the other 9, it belongs to the states, and public health falls into that domain. So most public health laws and regulations are state laws and regulations. And the federal authority in public health presumes interstate commerce, like with FDA, or specifically authorized by Congress, and so all the enabling legislation for the Environmental Protection Agency, for example, or for the Center for Medicare and Medicaid Services. So what happens is that when you're dealing with the federal government at the local and state level, you're dealing with money and the strings attached to money. Now, I work almost exclusively these days in global public health. So I was in Southern Africa all last week. Had a nice stopover, 24 hours in my shorts and t-shirt in Iceland, courtesy of a medical emergency, but it's all, it's all my life. So I'm going to talk largely about budget, and then I'm going to come back and talk about the global gag rule, which is something that I think everybody needs to be aware of. So the president proposed a budget called A New Foundation for American Greatness, which had a 26%, has proposed a 26% cut in global health funding. And parts of that are an elimination of family planning from global health programming for USAID, and also the ending the U.S. contribution to the United Nations Population Agency. It used to be called the Family Planning Agency, but they changed the name. I work a ton with the President's Emergency Plan for AIDS Relief, which was brought in under the George W. Bush administration, which is a huge player worldwide in buying antiretroviral drugs and the progress we've made in HIV. There's a 17% reduction proposed in that, and also an 11% reduction in the President's malaria initiative. So there, in addition to these cuts for foreign aid, for foreign assistance, there are huge cuts to public health service agencies. There's a proposed 16% cut to the whole Department of Health and Human Services budget, which includes 17% reduction for the Centers for Disease Control and Prevention, a 19% or $6 billion decrease for the National Institutes of Health, which is just unheard of on Capitol Hill, and a 31% reduction for the Food and Drug Administration, which is supposed to be made up by increased user fees. So there are 8 ways that the budget affects domestic public health. There's a big decrease in the CDC's domestic. CDC, by the way, is the Centers for Disease Control and Prevention, not the California Department of Corrections. We refer to that as the other CDC. So a $200 million decrease in chronic disease prevention at CDC. A cut for a variety of other programs, which I think are pretty out there. So emerging infectious diseases, this is where all the influenza surveillance goes on and sort of response to outbreaks of disease. For international CDC, a $2 billion a decrease, including a big reduction in the U.S. contribution to the Global Fund for AIDS, TB, and Malaria, which is the other big player for purchasing antiretroviral drugs. In the face of the opiate epidemic, a $250 million reduction to the Substance Abuse and Mental Health Services Agency, elimination of block grants, a decrease in the Vaccines for Children's program, and I think Professor Schwartz will talk about that later, and a reduction in some of the childhood lead poisoning programs. And if you want to talk about direct toxicants that have that are directly associated with poor neurodevelopmental outcomes, you need to look no farther than lead. So, Senate Appropriations Committee stepped up to the plate in September and basically rejected the cuts to health and human services. They passed an appropriations bill. It's the labor, HHS, and education get lumped together. That was $3 billion above the FY 2017 level and $27.5 billion above the president's proposed budgets. They not only restored NIH's budget, but added an extra $2 billion for sort of good measure, and $800 million for the opioid epidemic. And I think that it's useful to understand what this means in terms of cuts. So this is PEPFAR, the President's Emergency Plan for AIDS relief. This is all international stuff. It goes predominantly to Africa, although there's a little bit in the Caribbean and some in Vietnam. And the magic of antiretroviral therapy is not only that it helps people live and survive with HIV, but it also makes them non-infectious. Okay, so if you turn off antiretrovirals, first of all, you get resistant disease, right? Because you'll have a tail and you'll develop resistant HIV, and you'll have much more transmission. So you have a big bump in transmission. And this is looking at the kind of the idea of if we reduced PEPFAR aid along the pathway that's being proposed in the president's budget. We got scenario red here with 5 million, with an increase of, basically doubling of the AIDS incidence and the number of new cases of HIV. At current aid, it kind of continues to peter down. But with increased aid, which is what everybody's trying to push for, you can get more than a 50% reduction. Now, politics makes strange bedfellows and makes even stranger enemies. This is an op-ed that George W. Bush wrote in the Washington Post. As the executive and legislative branches review the federal budget, they'll have vigorous debates about how to best spend taxpayers' money, and they should. Some will argue that we have enough problems at home and shouldn't spend money overseas. I argue that we shouldn't spend money on programs that don't work, whether at home or abroad. But they should fully fund programs that have proven to be efficient, effective, and results-oriented. Saving nearly 12 million lives is proof that PEPFAR works, and I urge our government to fully fund it. We are on the verge of an AIDS-free generation, but the people of Africa still need our help. The American people deserve credit for this tremendous success and should keep going until the job is done. So, a little sniping behind his back. Now, so that's the impact of the budget. All up in the air, as you know. We don't have a final budget. We're working on continuing resolutions. It's all mixed up with the tax bill now. You guys know more about it than I do, although this was unlikely to be a pretty picture. The other thing embedded in the president's proposed budget is the global gag rule, which is also referred to as the Mexico City policy. So U.S. law has prohibited foreign aid funding for abortion since 1973, and was extended during the Reagan administration to require that foreign NGOs that receive U.S. global health assistance certify that they don't use their own non-U.S. funds. So it's not only the U.S. funds, but also it's all the other money they raise. Provide abortion services to counsel patients or to advocate for the liberalization of abortion laws. And this includes limiting conversations that health providers can have with their patients. So this has been in every Republican administration, was reinstated on January 23rd, but it only ties to the family planning budgets. What's happened now is that it's tied to the entire global health budget. Okay, so $8.8 billion. And these are the consequences of the cutting of foreign aid for family planning in the United Nations Population Agency. Fewer women receiving services, 3 million more abortions, 8 million unintended pregnancies. The birth rate for the world, by the way, is about 130 million people a year, so this is a fairly big chunk, right? And 15,000 maternal deaths. So the gag rule previously applied only to 575 million in family planning funds. The new order extends it to all the funds in global health, which is, it's huge reach, right? We basically increased this reach of this by 16-fold. So the Senate Appropriations Committee voted on September 7th to pass an amendment sponsored by Senator Shaheen from New Hampshire to overturn the global gag rule and restore all funding to the United Nations Planning Agency. So this is kind of where it sits right now, and we're waiting to see what plays. So I realize we're a little tight on time, so I'll move on and let somebody else talk. Thanks. Thank you.
Good afternoon, everybody. No slides for me here. Let me minimize this.
We always show slides at medical school.
I know. All right. Well, thank you, Dorit, and the organizers for the invitation. I'm going to talk a bit about, as George prefaced, what the Trump administration could mean, or has meant with respect to vaccination in the United States. You need the microphone. There we go. What vaccines and the Trump administration may look like. So the good story, this is somewhat more of an optimistic story than perhaps what we've heard, well, certainly than what we've heard with respect to environmental protection and climate change. And I suspect what we'll hear later today when we think about financial aspects as well as healthcare. So qualified optimism is what I'll talk about, but real concerns. And as these other topics today have talked about, we've been encouraged to think about regulation and deregulation rather broadly. Those are one of the tools for vaccines as well, in which there are challenges and risks to vaccination programs in the U.S., but I'll think also about the other kinds of tools in which the Trump administration can reshape, and probably not for the better, how vaccines are regulated, promoted, and used here in the U.S. So what three parts I'll talk about with you in terms of what were the signals we had prior to the election and since the election of Donald Trump in terms of what we might be worried about with respect to the future of vaccination policy. We'll talk about the tools that the president and the executive branch has at his disposal in terms of reshaping vaccination policy, some regulatory, some budgetary, as George spoke about, true for vaccines, and a few others in between. And then why, I'll end on an optimistic note, and I could tell the story two ways. I'll end on the high note in terms of why, at least so far, some of the worst fears of advocates of vaccines and the public health community more generally can take a bit of a deep breath, at least for now, that our current approach to evidence-based approach to vaccination has not been undermined or reversed in the way that we're seeing happening elsewhere in the federal government's portfolio. So, Donald Trump on vaccines, as some of you may have seen during the debates and during the election buildup here, we had clear signals that now President Trump, then candidate Trump, had been very sympathetic to ideas that vaccines were linked to autism. He spoke about it during the primary campaign. He tweeted about it, the idea that the anecdotes that he would pass along of a child, the sort of a classic story that causes such concern among parents, that a child was healthy one day and was showing symptoms consistent with autism or another developmental condition the next. And the president noted that it's horrible, that the vaccines in between must have been associated with that. That was a red flag. The triple red flag came prior to the inauguration when then President-elect Trump met with Robert F. Kennedy Jr. at Trump Tower and during one of those parades of meetings that happened in those weeks prior to the inauguration. And RFK Jr., the environmental lawyer and activist, as you also may know, is one of the most vocal, most prominent critics of vaccination policy, vaccination safety, particularly ideas going back to theories that mercury in vaccines were associated with vaccines, a historical and debunked hypothesis, but nonetheless, RFK Jr. is a champion of debates about criticizing the safety of vaccines and suggesting that our current overwhelming consensus of the medical and public health communities is unfounded. Donald Trump met with RFK Jr., who came down from the Golden Elevator and announced that he would be leading a vaccine safety commission appointed by the president to investigate these issues, to investigate the failures of the CDC in terms of vaccine safety. That didn't happen. That's the good news, not to spoil the lead here. But that raised all sorts of red flags. So we had reason to be worried about what tools, with all the tools the White House and the president would have in terms of what that would mean for vaccines in the current administration. So what can the president do, regulatory, deregulatory, and otherwise, to euphemistically put it, complicate, more accurately, potentially even devastate our vaccination programs and the success of our vaccination efforts in the U.S.? I think the most prominent is his Twitter account. So I think, we've seen the powerful bully pulpit, maybe literally, with respect to the president's tweets. And vaccination policy in the U.S. relies greatly on public confidence, maintaining public confidence in the safety and effectiveness of vaccines. That is priority one of federal policymakers, state and local policymakers, frontline healthcare providers, to remind the public that the widespread confidence that remains, despite a vocal, very vocal and passionate minority, that the confidence that's demonstrated in our high vaccination rates and their safety and effectiveness is justified. And it's not an exaggeration to say that a few tweets, a few sort of reopening long-settled scientific debates with the imprimatur of the president could certainly, at the very least, greatly complicate all of that delicate, sensitive work that happens to reassure parents who are confused or anxious or uncertain, who don't understand why there is a debate or if there should be a debate about the safety of vaccines. To date, there has been silence from the president's Twitter feed with respect to vaccine policy, and that can only be a good thing. So that's one crisis averted, at least so far. The second relates to the ways in which vaccination policy is developed here in the United States, both at the FDA in terms of regulation and at the CDC in terms of setting evidence-based vaccination recommendations, those gold standard vaccine recommendations that shape the vaccine schedule. Those both rely heavily on outside expert advisors, advisory committees at both agencies, particularly the Advisory Committee on Immunization Practices at the CDC, who work incredibly hard at shaping the gold standard for evidence-based use of vaccines. We've seen, and this is not the first administration, where scientific expert advisors have been marginalized or have been replaced based on concerns about either social or political issues, and we've seen it happening with the EPA already, where folks who have received grants from the EPA have now been excluded from scientific advisory bodies to the EPA on the grounds that I guess they're conflicted in ways that industry-associated environmental groups somehow are not. So we could see, we haven't yet, and again, that's my reasons for optimism, we could see a replacement of some of those expert advisors who are on government advisory committees to have individuals who are much more critical, who are representatives of the groups that Dorit interacts with, not always all that that pleasantly on the anti-vaccine side of things. Dorit's always pleasant. It's the folks who are not pleasant to her, to give them seats on these committees, to give them a voice and a platform and to legitimize those views. That has not happened yet, but it certainly could simply through the regular appointments that happens at the Department of Health and Human Services, if that were to occur. Concerns about the FDA. There's a whole separate set of meetings and conferences about deregulation and a deregulatory spirit at the FDA that preceded the election of Donald Trump, connected to the 21st Century Cures Act, that gave the FDA new tools and new powers to think about different kinds of evidence, different kinds of quote-unquote real-world evidence to include in their assessments of new technologies. That has raised concerns among our colleagues who work in drug regulation and drug law in terms of how that might weaken the evidentiary base by which products are evaluated by the FDA. That's true for pharmaceuticals, it's true for devices, it's true for biologics and vaccines as well. So that's a separate thread, a deregulatory thread that's important for vaccines. One more in terms of coulds, and then I'll talk about why we can be optimistic. Injury compensation. So many of you know, the Vaccine Injury Compensation Act and the Injury Compensation Program, developed in 1986, the no-fault compensation program that compensates individuals, usually children and their families, who have a confirmed injury associated with a vaccine paid in by a trust fund from an excise tax on vaccine doses, an interesting story Dorit or I are both happy, I'm sure, to talk about during the Q&A period. But there are important regulations that shape which injuries are deemed as compensable, which injuries appear on the vaccine injury table, which is one of the routes by which injuries can be compensated if they're on a predetermined table. The list of injuries could easily be expanded, notwithstanding objections under the Administrative Procedures Act and all of the sort of processes we've heard about. But that would be a tool if you wanted to legitimize vaccine safety concerns that have otherwise been refuted. That's a tool that could do it. But again, to date, we haven't seen changes on that front either. The spending piece George handled very nicely in terms of CDC funding threats. That's an area where we don't have as much optimism, except for the fact that Congress has a voice, as we talked about earlier today as well, in checking executive branch authority. There's been threats to the CDC budget generally, the Prevention and Public Health Fund, a separate story connected to the Affordable Care Act, a separate fund that now has become a really important piece of the day-to-day funding of agencies like the CDC, has been jeopardized by both the repeal and replace efforts in the Congress, and also has been sort of entangled in this renewal of the Children's Health Insurance Program, that to restore health insurance to those 9 million kids who receive health insurance through CHIP. One of the proposals that's made its way through the House, I think, would siphon still more money from this Prevention and Public Health Fund, which would have real consequences. So the spending story is not nearly a crisis averted sense, except for the ways in which Congress, at least with respect to the annual budget, has rejected the president's proposals with respect to the NIH, with respect to global health, and with respect to the CDC, and with respect to user fees to help fund the work of the Food and Drug Administration. So we have a spectrum of threats, a spectrum of concerns, a spectrum of tools that, except for spending, could be utilized by the president and his aides to affect real transformative change, not for the better, in my opinion, and probably the opinion of most of the folks in this room regarding vaccine policy. But why should we at least be able to not be taking to the battlefield to protest or fight? So far, if we accept the adage that personnel is policy, unlike the appointees, Scott Pruitt at EPA, Seema Verma at the Center for Medicaid and Medicare Services, which I'm sure we'll hear about later today, or Tom Price before his fascination with charter airplanes took him out of the government. Unlike those individuals whose ethos was really to undermine the traditional mandates and missions of the agencies they led in many respects, with respect to healthcare more generally, with respect to environmental protections. We have not seen that, and in fact, we've seen the contrary with respect to the appointees responsible for vaccination policy. A couple examples. At the CDC, Brenda Fitzgerald, physician, former state health commissioner in Georgia, has been unambiguous both before being appointed CDC commissioner and since then about referring to the link between vaccines and autism as debunked. She's been very clear about that, so one important sign. At the FDA, Scott Gottlieb has been very active in all sorts of efforts in the FDA's tenure, but he has been even clearer with respect, and I want to quote this from his confirmation hearing here, that he referred to the link between vaccines and autism as one of the most exhaustively studied questions in scientific history, and we need to come to the point where we can accept no for an answer and come to a conclusion that there's no causal link between vaccination and autism. And Commissioner Gottlieb has been similarly active in promoting vaccine safety on Twitter and in other statements since being confirmed. Same is true for the Surgeon General, a former state health commissioner himself, who was favorably endorsed by the state and local health commission, NACHO, I should say. This county and city health official group is a staunch advocate for vaccines. And at the NIH, Francis Collins and Anthony Fauci have been retained in their positions, longtime servants and well-respected scientists and strong champions of vaccines to boot. So we've got reason to believe that if these individuals and the teams that are in place are permitted to continue doing their work and are able to, as these scientific agencies need to do, to carry out their activities free from interference, having the resources, the budgetary piece is not one I want to minimize, but at least so far we have a story of contrast that can, at least with respect to the different fronts for energy and activism and engagement, we shouldn't let our guard down. There's real risk, there's grave risks. Vaccination programs and policies are fragile and can be weakened very, very quickly. But to date, we have a story of cautious optimism going forward. So I'll stop there and look forward to the rest of the session and the day. Thanks very much.
It's another Schwartz without slides. It's going to be I was always told that when God was giving out slides, she had run out of them by the time she came to Schwartz. I don't know if that's the actual story, or used to be we had to distinguish ourselves from the medical school lectures. I'd like to take this in a slightly different direction and talk about how we might look at deregulation generally in the area of bioethics more generally. And I should begin by saying that when we think about deregulation, we do not, by and large, think about bioethics. We think of a few issues and we've heard about them. As Professor Price mentioned this morning, too, that probably the issue of medical marijuana deserves honorable mention when it comes to subjects on which there's been discussion about deregulation. But by and large, when we think about bioethics, we don't think about deregulation. We think about regulation. We don't think about bioethics. And I think it might be worth paying more attention to that issue, actually trying to think it through and ask why, in fact, there's an interest in deregulation and how we might think about that interest in deregulation as a principled matter as it applies to bioethics issues. Because in some ways, it's particularly appropriate to think of the libertarian underpinnings of deregulation when we think about the freedom that we seek often when we make claims based in bioethics. Let me say first that we should start probably by asking, why is it that the purist in the Trump administration, if there is such a person, why is it that someone who is a real believer in deregulation, a true believer in deregulation, would in fact support that position? Why? What is the reason that someone would say we should, as a general matter, deregulate? And there are a couple of different reasons, a couple of different kinds of reasons. The first is often the deregulation is entirely instrumental. It is a way to achieve some other end. It may be a way to lower costs for industry. Maybe the way to lower costs for industry. The goal is lowering costs for industry, and deregulation is just one way to do that. Maybe it will improve the economy. Maybe it will reallocate costs or reallocate risks from corporate entities to individuals, or from certain kinds of companies to individual participants, to subscribers, to health insurance subscribers, to patients, to customers. Perhaps it'll provide an incentive for investment. There are lots of potential instrumental values that can be served by deregulation. But when you listen to, I'm I'm tempted to say that the philosophers in the Trump administration, but those who at least have been supporting the notion of deregulation, it sometimes sounds like the real goal is something more than these instrumental uses. There is an inherent value in deregulation in and of itself. It is intrinsically good, even if it has none of these other instrumental impacts. And you might look at, we might quote Naomi Rao, who is the one who is running the deregulation movement for the Trump administration. See, she says, regulatory reform, of course, is in some way fundamentally about protecting individual liberty and property rights. We also see these reform efforts as a key part to restoring constitutional government. And you may disagree with these values, and you may decide that these values are entirely inappropriate, but we ought to recognize that, in fact, these are seriously maintained values by those people who, in fact, are among the group that is looking to support deregulation. So in the classic libertarian approach, freedom from government restraint is a very important freedom. It's an important value. The less government there is, the more freedom there is. And through deregulation, we remove regulation, obviously increase freedom. And it's highly worthwhile, no matter what the effects of that may be. It may be highly worthwhile just to have created that additional space, just to have created that additional freedom. Of course, I point out that this administration isn't the first to be taken by this theory. Others have been as well, and we think about, for example, the bakers in New York in the just more than a century ago, and we know that if the bakers in Utica want to agree to working hours that might otherwise pose some risk to them in their employment, well, that there is an important underlying value that says we ought to allow them to make that choice. If they want to put their health on the line, that's their prerogative. That is fundamental to living in a free society. And at least under the circumstances of the Lochner case, and I can't help but quoting one line from Lochner's brief to the Supreme Court, actually, to the U.S. Supreme Court, which pointed out that the bakery of the present day is well ventilated, comfortable both summer and winter, and always sweet smelling. So maybe that may have justified the Lochner opinion more than the general theory of economic freedom, which in fact was the base of that theory. But we can see that that theory did not die a century ago. In fact, that's the theory that is behind deregulation now, or at least part of the theory, part of the reason for the interest in deregulation now. And if that theory didn't die, if it was only asleep, I think we can look at what we've seen and talked about today and see that it is in fact coming out of hibernation, and that it may be hungry, and we should beware of what will happen if that theory again develops the strength that we saw it had in the Lochnerian era. Now, as I mentioned, among bioethicists, there is very little discussion about economic freedom and the right to make economic decisions. There probably should be more discussion of that, but there isn't. Some believe that economic liberty is largely irrelevant in these areas, and the Trump administration has also been willing to leave behind that pure libertarian analysis when it comes to looking at bioethics questions. And as we don't have to look very far to see, in fact, there are other values, by and large culture war values, which trump those libertarian values almost, very consistently, almost always. And it may be worthwhile looking at some particular issues in bioethics just to get a sense of how the administration is using the libertarian values and where it's ignoring those libertarian values and trying to determine how to regulate conduct that regulate the kind of conduct that we talk about as having bioethics implications. And it may be worth starting with the two issues that seem like they're the most appropriate for deregulation, that is, right to try laws and medical marijuana laws, and then look at how the administration has handled such issues as abortion, contraception, end-of-life care, and aid and dying in particular. And perhaps the most obvious place for the application of libertarian principles and for deregulation, and the most successful in the last decade has been right to try laws. A state right to try law provides that essentially competent terminally ill patients for whom no approved therapy is available can have access to unapproved therapies under some circumstances, as long as those unapproved therapies have made it through phase 1 safety studies. This was unheard of a decade ago. There are now 37 states which have passed right to try laws. It's in effect in 37 states, although there have been very few cases where people have actually sought care under the law in those states. And the administration has been, by and large, highly supportive of those right to try laws. The claim in those right to try laws is the Food, Drug, and Cosmetic Act is a regulation. It's an inappropriate barrier that makes it impossible to get the kind of care that, in fact, we need and deserve. And so, in fact, through state right to try laws, we can overcome federal laws, federalism problems aside, obviously, and provide people with the opportunity they wouldn't have otherwise. It's, in a practical matter, not terribly successful. I mean, insurance companies aren't going to pay for care under these circumstances. The doctors who are providing these cares or supervising the care probably know very little about how these therapies are going to work because, in fact, they haven't been thoroughly vetted yet. There may not be very much information about them. People are probably wasting their resources, which might be spent on palliative care or other forms of care. But nonetheless, it is a straight application of a libertarian principle that says that the Food, Drug, and Cosmetic Act is an inappropriate barrier, and we'll simply deregulate effectively, if we can, through state law. You would think that with that approach, with regard to right to try laws, you'd see the same response by this administration to medical marijuana laws, but as you know, we haven't seen that response at all. The response to medical marijuana laws has been entirely different. The libertarian argument, it seems, is the same. The deregulatory argument against what the federal government has done to regulate the use of medical and other marijuana, you'd think would be the same, but it's different. And why is it different? We know, again, from Attorney General Sessions, what do we know about marijuana? We know that good people don't use marijuana. And that really is the difference, it seems, between the right to try law and medical marijuana laws. It's hard to find other formal distinctions. It's a political distinction based on what good people do. As you know, and as we heard earlier today, there is a provision in the current budget that provides that the federal government won't enforce federal marijuana laws against individuals who are currently complying with all state laws in selling or using medical marijuana. The Attorney General has asked that that not be included in the budget for the next fiscal year. It very well may not be included in the budget for the next fiscal year. The move with regard to medical marijuana is just the opposite from the move with regard to right to try laws. In fact, the move is towards essentially reinstating that federal regulation to control that use. I'd be tempted to do the same analysis with abortion, much more complicated, but we've heard actually a fair amount of what's happening with regard to the right to an abortion. Also with contraception, which, as you may have noticed, is no longer contraception. It's now fertility awareness. It's the new term for the administration to refer to contraception. But in those areas, too, you look at the underlying principles and you can say that, in fact, with abortion most clearly, but with contraception as well, that there are substantial libertarian principles, which are exactly those kinds that vindicate the classic libertarian analysis that we thought at one point maybe the Trump administration might be interested in, but in fact, they are overcome, they are outweighed by culture war issues and by political issues, which just render them effectively meaningless in determining policy. Let me just mention one other issue, and that is aid in dying. This has really followed the politics, as you know, of abortion. The primary opponents to aid in dying laws are right-to-life groups. Politics are identical, and as you look to Washington and see what the federal government position is with regard to aid in dying, you can see that their position is essentially the same as it is in abortion, with regard to abortion. This is not a libertarian issue. This is not a matter of individual freedom. Good people don't choose aid in dying. Attorney General Sessions hasn't said that directly yet, but that's the implication, I think, and that's the only consistent principle we can find to apply under these circumstances. Good people aren't going to engage in aid in dying, and as a result, the interest of the federal government is to make it as difficult as possible, to provide as many obstacles as possible to those who seek to participate in aid in dying. Well, we've heard that the administration is committed to deregulation. That's in part because the principled commitment to economic liberty and the right to be free of unnecessary constraints on individual freedom push this administration in a very principled way to look to create, to find places where deregulation might be appropriate. But we can also see that these principled deregulatory commitments have been completely overcome by other values, primarily related to culture war values, to pelvic morality. And when we look at the actual application of these principles, at least in bioethics, we can see that they've become, that although they're significant, they're always accounted for. They rarely, in fact, are the basis of this administration's policy.
Would the panelists come back so that people can ask questions?
Is this on? Yeah, it is. Well, the panel that I was on, the Institute of Medicine panel that I was on, we were primarily charged with answering the question whether the U.S. health disadvantage extended across, all health indicators and all age groups, and they didn't give us the time that would have been needed to even, make a dent in the question why. But we, of course, couldn't avoid, thinking about it and talking about it. And what the panel came to the conclusion was that that very likely it had to do with differences in social policies, and particularly policies that protect families with young children, and that it wasn't any one thing. Part of it is guns. So it gets back to some what we would call cultural issues. But that's my conclusion, that I would look at, broadly at the web of interacting social policies, because I think we also hypothesized that some of it might have to do with medical care, that although the U.S. spends more on medical care by far than anybody else, our system is also appears very, very fragmented and very specialist oriented, with weakness at the primary care level, whereas strong primary care orientation and integration of services tends to characterize the healthcare systems of most of the other countries that do better than we do on life expectancy. So medical care issues could be making a contribution to our worse life expectancy.
I think there are a couple of other things to just add to it. One, smoking. which is kind of going, you live in California, it's all gone away here, but, walk down towards BART, that's who we're talking about here, right? Yeah, and drug use, yeah, everything, all of the above,
Although
drug,
we,
as we now say, drug use disorder.
yeah, although for a while now, our smoking rates have been better
Yeah.
than that of many of the countries who are doing better than us on life expectancy. Overall, the one country among we looked at 17 other countries that they were affluent and they were democracies, because we thought that would be most meaningful for the comparison. So Denmark was one of them. And Denmark was the US was the only one of the countries that consistently ranked at or near the bottom. Denmark came close to getting the booby prize. And there was actually somebody from Denmark on the panel, which made it more interesting. And his theory was that they've been really slow on smoking. They really have not gone on the bandwagon of all, the range of policies that you can implement to get people to smoke less, and that was why a lot of Denmark's indicators were bad on a number of indicators, but not as many as ours.
Ton of questions, but I'm going to just restrict it to something, not to be overly topical, but sexual harassment is a chronic stressor in the total routine of health, especially for women of color. I don't know what we can do with that, but now's the moment, maybe. That's one thing. And if I could get in one more, in a lot of European countries, preventive medicine includes like things that Quaker schools do here, teaching meditation, having an hour and a half lunch at which you learn to eat healthfully and sanely, things that are not even part of the American ideology. And also I have wondered about vaccines, why my cousin who's in medicine had to import vaccines from Europe because she believed they were far safer, both in terms of dosage and storage than anything in the United States. So that's a bunch of questions, but so sexual harassment, vaccines, and why we don't just teach preventive medicine where we have people who can teach in school.
Well, I'm not at all an expert on sexual harassment, but it's an opportunity for me to say that anything that is a source, a prevalent source of stress, could be part of the picture. I mean, we don't have this statistics on a population base yet, although some of what's been going on suggests that it's in fact very, very widespread. And if that's true, that could be a contribution. And I'll take advantage of that opportunity to say also that racism, I think I mentioned this, but only in passing, racism as a source of chronic stress for people of color could be a very, very big and bad piece of the puzzle, and it sort of functions in two ways. One is by tracking people of color into less socioeconomic opportunity than with all the health disadvantages that come with that. And then the other with direct psychological effects. And there's a growing body of scientific literature now documenting health effects of experiences of racial discrimination. And it doesn't have to be overt, in your face actions. It can be subtle, it can be ambiguous, but if it's chronic, it can take a toll and wind up in damage to organs and systems along the lines that I was talking about on the vaccine safety.
I'm going to jump in. No, so 2 points. One, I'd be interested, and we can talk afterwards about mechanistically how the importation of unlicensed vaccines happened from Europe. Not that I'm an FDA, enforcement agent, but I would, I'll show the badge. So that would be interesting. But the broader question is the point there that it's representative of exactly, and I suspect your family member or friend is not alone in having the pervasive doubts in the integrity of the U.S. vaccine safety system such that she would feel the need to go to such lengths to do it. Now, that's been the perennial challenge for vaccination policymakers and public health makers for a generation or longer, really as long as there have been vaccines, if we really want to historicize it. And that's what advocates of vaccines are up against, and that's why, it's fragile.
It's legal for me to.
If they're licensed here, then they're not that different.
Yes, if they're licensed in the U.S., then
They're not different.
sure, then they'd be regulated by the FDA the same way that the products she was seeking to avoid would be. So it's a semantic thing that gets your
Dosage,
Mhm.
everything, the way that the
No.
dose is lower after the
Mhm.
and also that she wasn't so secure about storage
Mhm.
in the state that she was on the faculty of medicine.
Yeah. So let's chat afterwards. I'd love to hear more about this.
But it's interesting, it supports Jason's notion that, in fact, that sort of the public respect for vaccinations and for the information we have about vaccinations is fundamental. And that's been true at least from the time of Jacobson. Because you look at Jacobson and you see, in fact, it was that public concern about both efficacy and safety that led to that litigation.
Yeah, and you can go back earlier to Victorian England and smallpox vaccination in the 19th century, where there were the same debates about why are these vaccines as safe as the government believes them to be? Why should we require these vaccines? In terms of enforcement, this is as old as there have been vaccinations, to be sure.
Some of my best friends are bioethics. Yeah, oh, sure, yeah. It's not a well-defined category, but.
I'm thinking possibly one as a because public policy during reduction and bioethics. We're not saying overtly that when we reduce particular health insurance policies are now again, like they did back in the 1990s, telling people you need to make sure that your emergency room visit is a correct visit. But you need to know the difference as a patient that may have no medical training or knowledge at all, and maybe from one of those really poor undereducated areas. You should know the difference between a chest pain and cardiac versus gallbladder, pancreatitis, and when they work it up, when they find out that like a cardiac, which nothing to do on the outpatient basis, but therefore we're not paying for your ER visit. That's the stuff that's happening. And no one talks about that, and why not?
Oh, and it's certainly a really good point. And it turns out, yeah, and when you start talking about those issues, it turns out that people across the political spectrum will agree on some of them, on many of them, in fact. I just wanted us to be clear that there are different views, different ethical views, different basic societal views that do affect how we view these policies. This is a very communitarian group. We are in the midst of a communitarian community. I'm certainly on the communitarian side of that spectrum, like everyone else, like most people here. Like everyone, like most people here. But there are, and there are people who say we as a community have an obligation to take care of each other. And that's our first obligation and our primary obligation. But there are people who say that, in fact, the primary obligation is to be able to exercise, the primary value in society is to be able to exercise our freedom to be able to make these choices. And that that the disagreement in those two principled approaches to the role of government and the role of society will often yield different results, even when you do consider the facts that you raise.
We're kind of
Exactly, and, and then back to the other question, when you talked about how that was good, for your generation, and, our biggest issue in women's health is poor housing, poor education, low income from the studies, so then they considered, maybe should reduce the numbers of healthcare. Getting more help with information. And increasing training.
I'm sorry. I'm sorry. I'm really sorry to cut you off, but I'm really sorry for everyone. We're simply out of time, and I want to give people a chance to have a break before the next panel. I hope people will come to the panelists and continue the discussion here. And again, I'm sorry to cut us off. We have a very full schedule, and I hope we have as engagement in the other topics. Thank you to all our panelists.
Jason, nice to meet you.
Hello, everybody. Let's go ahead and come back. I'm Jaime King. I'm a professor of law here at UC Hastings, and I'm also the co-director of the UCSF UC Hastings Consortium on Law, Science, and Health Policy, which is helping to sponsor this event. I'm really glad that all of you could be here. We have a really exciting panel, as they have all been so far, but another really exciting panel for you here today to talk about deregulation in the healthcare system and what the Trump administration has been trying to do over the course of the last year. So first up on this panel is going to be Dr. Andy Bindman. And he's a professor of medicine, epidemiology, and biostatistics, and an affiliated faculty member at the Institute for Health Policy Studies at UCSF. He was formerly the director of the Agency for Health Research and Quality, ARC, until the end of the Obama administration in late 2016. And in 2009 and 2010, he was a Robert Wood Johnson Health Policy Fellow on the staff of the U.S. House Energy and Commerce Committee and helped draft some of the legislation associated with the Affordable Care Act. And then from 2011 to 2014, Dr. Bindman served as a senior advisor to the U.S. Department for Health and Human Services, and also within the Office of the Assistant Secretary for Planning and Education. So he has been intimately involved with the drafting and the rollout of the ACA, and I think there's no better person to really tell us about the the existing state of the regulations that were a part of that law, and then what some of the important regulations like the CSRs and everything are. The Cost Sharing Reduction Act was part of that. So he's going to start us off with giving us the lay of the land of regulation in healthcare, and then go into some of the details about the cost sharing reductions, removals imposed by the Trump administration. Next up, we'll have Micah Berman, who is an associate professor of public health and law at Ohio State University's College of Public Health and the Michael E. Moritz College of Law at Ohio State. And he, as he said in one of his questions, he is really more of a public health person that we have co-opted onto this panel because as part of his research, he has done a lot of looking at the implications of the Trump administration's executive orders. And he's going to talk to us about the potential implications for the healthcare system of those executive orders and what we're likely to see going forward in that instance. Next, after Micah, we'll have Erin Brown. And Erin Brown is an associate professor of law at Georgia State University, and she's also a faculty member of their Center for Law, Health, and Society. Erin has focused a lot of her work on regulation of the healthcare system. She's focused a lot on regulation of healthcare markets, on pricing, and things like that across the board. And what she's going to talk to us today about is her work on the role of states. And I think if anything we've learned about the Trump administration, this has sort of come up a lot, is that as we deregulate at the federal level, we're going to need to start to see a lot of states stepping forward to take up the mantle of that. And so Erin has done a lot of looking into what states can do, what options they have, and then where there are impediments to doing so via ERISA and other things from other versions of federal. And so she's going to tell us a little bit about that. And then finally, we're going to hear from Dr. Renee Hsia, who is a doctor of emergency medicine, a professor of emergency medicine at UCSF. She's also a practicing emergency medicine physician at the Zuckerberg San Francisco General Hospital. And she is the director of the PLACE, the Policy Lab for Acute Care and Emergencies. And she's going to tell us a little bit about what's at stake here. She's going to put a personal face on it and tell us about the patients that she sees that would suffer from a lot of the deregulatory attempts, especially in Medicaid. And so attempts to limit funding for Medicaid, shut that down, and minimize that population. So she's going to really give us a sense of what's happening there. But so without further ado, I will turn it over to Dr. Andy Bindman. Thank you. Let me take your slides.
right. Well, thank you very much, Jaime, for that nice introduction. It's a real pleasure to be here, to have a chance to be part of this really interesting conference. Speaking of interesting things, if any of you ever wanted to be involved in opera, you are in it. This is, our lives have become, if it weren't real life, I guess it would be kind of fun and dramatic the way an opera is. But federal health reform and who knew healthcare could be so dramatic, and never mind how complicated it could be. But this has really been quite a roller coaster ride, I think, for all of us. And I just want to make sure, as kind of like a basic fundamental place of starting, that the ACA is so talked about, kind of maligned, celebrated, all those things, and it's really built on a very relatively simple foundation. But I think it's important because sometimes that is not part of the conversation we have. And so I just want to kind of remind us all what the essence of it is, or why it was constructed the way it is. So first of all, if you go back to the pre-ACA days, the newspapers used to be full of stories about people who couldn't get health insurance because basically they had this thing known as an illness. And there was this weird disconnect between having an illness and being able to go to the doctor because you didn't have health insurance. And so both sides of the aisle actually agreed that we needed to address the problem of pre-existing conditions and getting people to have the ability to get health insurance. And when you talk to health insurance companies at the time, they said, okay, we're not opposed to the idea. The problem is if it's done on a voluntary basis, the only people who show up are when they're sick, and as a result, they're very expensive. And so the way to get everyone into the pool, of course, was to think about something like an individual mandate, to create an expectation that regardless of what your health status is, that everyone gets health insurance, and then at least there's the possibility of those who are not sick coming in and helping to cross-subsidize those who are sick, and so that when they become sick themselves, there's an opportunity for there to be resources for them. So that sounds workable, but then there's this other problem, which is that health insurance is an expensive product. And so how do you make sure that everyone has access to that? And so the final third leg of the stool, if you will, is making sure that people of lower means have an ability to buy health insurance under the mandate. And what the ACA did was basically create two pathways for that. For the very lowest income individuals, up to 138% of the federal poverty level, the idea was to expand the Medicaid program and to get rid of some of the rules that kept out individuals such as adults who did not have dependent children to be able to get Medicaid because they were low income. And then for the next group of people between 138% and 400% of poverty, to offer them essentially a sliding scale set of supports to help them buy insurance through the marketplace, or what we call Covered California here in California. So that's basically how the whole thing works. Now, when I say the whole thing works like that, the law was written. It was, of course, you saw it's a very thick law at the time that it passed. Implementing it is a very complicated thing, which is sort of the topic of what we're talking about today, sort of the regulations that go into that. And the ACA was famous for having literally thousands of places where the word secretary showed up. In fact, when I first went to Washington, I kept wondering who these secretaries were. But it turned out that's just a nice word for a cabinet secretary. But the law just says secretary shall, and this is just sort of instructions from the Congress to the Secretary of HHS to implement or write regulations to assemble the law. And as many people have said, the ACA was not a self-assembling law. It required lots of active steps. And I think a big part of what this conference is about is to say, well, if you don't want to put those steps together, what opportunities do you have to make the thing work or not work, depending on the choices that you make? So this guy was very involved, in fact, trying to get the regulations and for all of it to work, because obviously Obama was a big advocate for this law in the first place. That's why some people call it Obamacare. And it has had certain kinds of successes, right? We've seen that more than 20 million people have gained coverage. We've seen a decrease in disparities in coverage by race and ethnicity. It doesn't mean the disparities are completely gone, but they certainly have shrunk. We've seen in California is the state with the biggest single reduction in the uninsured rate of any state. We've gone from a little over 17% to close to 7%, or a little over 3 million Californians are still uninsured, but that is a dramatic reduction from what it was. And if you go to a place like where Renee is going to talk about, San Francisco General Hospital, which is the public hospital here in the city, in 2016, we only had 3% of our hospital days were uninsured patients. That's an unbelievable drop. When I was in training and practicing there for many years, it was not uncommon for about 35 or 40% of the bed days to be uninsured. So this has been a dramatic change related to insurance coverage changes. So as great as that sounds, how is it that there are others who feel differently? Well, this is sort of the critique that comes from the Republican side that basically says that Obama and the Democrats have been too excited about the coverage changes and what impact it's had on access, and haven't paid enough attention to the fact that the way this has been accomplished has been by expanding entitlement programs like Medicaid and creating new entitlements such as the premium subsidies that help lower income individuals buy insurance through the exchanges. They also complain about the fact that one of the things that happened under the law was to create something called essential health benefits, which is this concept of saying what health insurance fundamentally is as a product when you go to sell it. Going back again to the pre-ACA days, there used to be stories about individuals who would buy insurance, thought they had insurance, then they would get breast cancer or some other horrible disease, go to the doctor only to find out that the small print of their policy said, this is health insurance except if you need to see a doctor, or something along those lines. And so what the ACA did was to create standards of what the product could be that you could sell, so that as a consumer, you really knew what you were getting. And there are basic categories of it's going to cover doctor visits, hospital visits, ED visits, medications, all the things that you would associate with healthcare, but it said had to be basically included in there. And the impact of that, of course, is that just like when you were making cars and suddenly said airbags had to be a basic component of them, the price of the car goes up because now they all have airbags in them. But as a society, we decide, well, that's an important thing for safety point of view, and so we do that. And so that's, anyway, one of the complaints is that these essential health benefits have raised the cost of health insurance, but you can see what the offsetting argument is to that. And then finally, the individual mandate, even though this was a concept that frankly was developed by the Republicans and was implemented in Massachusetts by a Republican governor, the individual mandate has now been identified because, first of all, the public generally doesn't like the idea of mandates, and Republicans have galvanized around this as something that they are opposed to as well, telling people that they have to have health insurance. So, of course, there's been tremendous attempts as part of that opera picture that I showed you to use the legislative mechanisms to try to repeal the ACA. Those first attempts have all failed, although, of course, we're now living in a day when there's going to be another attempt now through the guise of tax reform to perhaps take on some of this. So the legislative attacks have not gone away. But I think the focus of today is also about what are ways that those who do not like this law can sabotage it even without a change in statute. And so some of the things that have been identified is that when the marketplaces are open, like covered California or the federal exchanges in other states and so forth, there has historically been a 3-month open enrollment period, just like probably many of you who work for companies that have open enrollment to get insurance. I'm in the final days of mine at UCSF where we're signing up for our plans for next year. Open enrollment has been historically a 12-week period up until this year. The Trump administration decided to shrink that down to 6 weeks. And it's known that healthier individuals are the ones who tend to sign up later on. So in fact, if anything, it's going to undermine bringing healthier people into the marketplaces. It's also not promoting the open enrollment. So there was just, I think, a poll out today that said about a third of Americans had no idea open enrollment was going on in the marketplaces. Let's hope that those are the 1/3 who don't need the marketplaces. But fundamentally, this is something that people need to know about, to go sign up for it. We're very fortunate here in California that Covered California has put some of its own money into promoting this in the state, but states otherwise, for the most part, aren't doing this and rely on federal money. So this was cut dramatically under the Trump administration. Third, they decided that, if you remember famously when Obamacare rolled out, that healthcare.gov, the website to enroll, didn't work very well, and the administration was ridiculed related to that. Well, this administration decided that a good time to do maintenance on the website is on weekends, when of course most people would have enough free time to be able to sign up for the plan, and so they're purposely taking the healthcare.gov down on weekends when people would want to make use of it. And then finally, I want to mention what's going on with the cost sharing reductions, because this has gotten a fair bit of recent press, and we're going to go into this in more depth on the panel. But cost sharing reductions in general are a way to help low-income individuals who get the insurance through the exchange to be able to get that their co-payments and deductibles and so forth covered. So I just want to say a little bit about the cost-sharing reductions and clear up something that I think many people sometimes get confused about it. So first of all, whenever I talk about health insurance marketplaces like Covered California, I show pictures of farmer markets, because that's essentially what marketplaces for health insurance are all about. It's basically bringing the different insurance companies. They aren't selling oranges and apples, but they are selling different kinds of insurance products, and they're able to be compared directly because there are, in fact, the use of these things like metal tiers, bronze, silver, gold, and platinum, which correspond to the different average amount that those insurance will pay of an individual's healthcare needs. Bronze would pay 60%, silver 70%, gold 80%, and platinum 90% of the costs. So first of all, a consumer can compare those different products directly, just like you can taste the oranges from one stand and compare it at the next one and decide which farmer you want to buy from. Now, there's two types of ways that the federal government actually helps to help lower income individuals be able to buy health insurance. One of them is called premium tax subsidies, and this is basically to help offset the premium itself. And this is not contentious. This is not an area where there's a challenge going on about whether the Trump administration is going to continue this or not. This is in law, and it's ironclad. And it basically covers people between 100 and 400% of the federal poverty level on a sliding scale basis. The amount that is given to individuals is benchmarked against the price of silver plans in the marketplace. About 80% of people who buy health insurance through a marketplace get one of these tax subsidies to help them offset the cost of insurance. And the federal government spent about $40 billion on this in the last fiscal year. The other part of the way the federal government helps people get insurance through the marketplace is through these cost-sharing reductions. And what these are is for the lowest end of the individuals who are eligible to buy in the marketplace with federal support. It covers things like co-payments, deductibles, other kinds of co-insurance. And there's, again, it's a sliding scale where those who are closer to the 100% end of the scale get more of this subsidized than people who are slightly higher. These individuals must choose a silver plan to be able to take advantage of this. And what it does is at the lowest end of the financial spectrum, it actually raises the actuarial value, how much the insurance will cover, from 70%, which is the normal silver plan, up to 94%, because it's paying basically the deductibles, the co-payments, things like that. And about 55% of people who get insurance through marketplaces actually are able to take advantage of these cost-sharing reductions as well. And they came out to about another $10 billion in 2017. So if you think about it from the insurer point of view, they get money from four sources. They get premium contributions from the beneficiary. They get the premium tax credits, or those subsidies for premium, which is not under debate. They get payments from beneficiaries for co-pays, deductibles, things like that. And then finally, they get these cost-sharing reductions from the government. So there's kind of four sources. What's happened, though, is that the Republican Congress in 2014, when the House flipped, challenged whether the language of the ACA adequately appropriated money for the cost-sharing reductions. And they challenged this in court, and in 2016, the court actually ruled in favor of the Congress. This was a surprise to many. I'm not a legal expert. Perhaps others will explain how this is possible, because that certainly wasn't the intention when the law was written. But nonetheless, both the Obama administration appealed this and continued to be able to make these payments throughout the remainder of its administration, and the Trump administration continued them, at least at first, when they came into office. But more recently, there was an executive order to end the cost sharing reductions. This actually happened in October of this year. And President Trump said that these are a bailout to insurers because what basically happens is the money for the cost sharing reductions isn't given to the beneficiary. It's actually given directly to the insurance plan on behalf of the beneficiary. And so he characterized this as bailing out the insurance plans. By cutting off this money, of course, it sounds like a soundbite where you'd say, hey, this is going to save the federal government all this money that we were spending to bail out the insurance companies. And of course, it was also intended to undermine the ACA and to not make it work so well. But it is complicated because, in fact, it sets off a cascade of events that's important to understand in terms of how these things play out. Without the cost-sharing reductions from the federal government, the insurer makes up the difference by changing the premium. Remember, I showed you the 4 sources of money they get, so when they get one of them cut off, they're going to look for another one to actually keep themselves whole. And so what they've done is they've raised the price of the silver plans, which used to get these cost-sharing reductions, and the average premium has gone up about 20 to 25%. This raises the federal premium subsidy automatically because the rule about federal premium subsidies automatically shadow what the pricing is for the silver plan. So suddenly the federal government, so the price has gone up, but for those who get a subsidy, so has the subsidy to support their premium kind of match that. And so, in a sense, those who are getting cost-sharing reductions are completely protected from the fact that the cost-sharing reductions have been held back. The premium has gone up for their plan, but the federal government is paying that. This higher subsidy is available not just for people who are getting silver plans, but for anyone who's getting a subsidy, because the subsidies are tied to the silver plan. And suddenly this makes other plans, it makes like the bronze practically free. It could make the gold plan seem much more affordable because, in fact, the amount of subsidy is gone up, but the only plan that's gone up has been the silver ones. So the only people who sort of get hurt by this are those who don't get any subsidy who want to buy a silver plan because now the premium has gone up a lot and they don't have the support coming from the federal government to support that. And the net impact of this, as judged by the Congressional Budget Office, is that maybe initially this will sort of scare people off or they won't understand it, and there might be a drop in coverage of as many as 1 million people in this first year when this is implemented. But that probably within a couple of years, people will start to realize that the subsidy is so much greater now that it makes it possible to actually get a bronze plan essentially for free or to pay relatively little to be able to get a gold plan and so forth. And the bottom line impact of all this is that it's likely that there'll be both a slight bump up in how many get insured, despite the fact that this was meant to undermine and sabotage the ACA. But the biggest hurt is actually to the American people because the CBO estimates that this shenanigans is actually going to add $194 billion to the deficit. So it's just a way to sort of show, and I'll just stop there by saying that there's a lot of activity to try to sabotage and use communication strategies to undermine the ACA. But because of how complicated this all is, sometimes attempts to sabotage things actually turn out to be things that could, in the long run, be beneficial to getting more people covered. Thanks very much.
All right. Well, thanks for having me here. This has been a really interesting day and really interesting to see some of the different connections between these different fields. I'm a little surprised that it is past 2 o'clock in the afternoon and no one has mentioned Steve Bannon yet. And his famous quote when he came into office that his purpose there was to deconstruct the administrative state. He's no longer there, but certainly set some things in motion with that goal. It turns out that deconstructing the administrative state is a extremely hard thing to do. Just like Donald Trump found out that healthcare is complicated, deconstructing the administrative state is pretty complicated. But what it is possible to do is kind of throw sand in the gears or gum up the works or do other things that make it so that the administrative state doesn't really function during the course of this particular administration. And doing that the way that the administration has huge consequences for healthcare, for public health, for health, because a lot of healthcare law and public health law is administrative law. And as was mentioned the first presentation this morning, to some extent what the administration is doing is building on what past administrations have done, and to some extent we're seeing some things that are new. So there's so much to talk about in the healthcare context. I'm going to focus in narrowly on executive orders that this administration has issued. I'm going to focus most of my time on the one that's been mentioned a couple of times already, Executive Order 13771, which is the so-called 2-for-1 rule, focused on reducing regulations. If there's time, hopefully, for me to talk about it, there are two executive orders that have been issued that are more specific to healthcare regulation. I'll talk about those as well. So the big one, the January 30th one, is not specifically focused on healthcare. It's about regulations generally, but as I'll talk about, it has implications for health. It does two main things. So I'm going to dive into it a little more depth than previous speakers talked about it. So it does two main things. The first one is it says that for each new significant regulatory action, and that's generally defined as a regulatory action with at least a $100 million impact on the economy, at least two prior regulations by that same department have to be identified for elimination. That's the 2-for-1 part of the rule. So I'll talk about that a little more, but that's the first piece of it. But what we haven't talked about yet is the second piece of it, which says that each department now has to live within a so-called regulatory budget. And what that means is that for each agency or each department, the cost that there has to be a budget, and the agencies have to meet that. And the way they do that is that they have to calculate the cost that new regulations are imposing on businesses, subtract the reduced cost from regulations that they've taken away, and that gives them the amount that they have to fit within their budget. And what the executive order did is for fiscal year 2017, which is now over, it set that amount for all agencies at 0. So any new costs imposed by new regulations had to be totally zeroed out by regulatory actions that took away existing costs. It's a little unclear how this is going to work going forward. There was a memo sent out by Naomi Rao, the administrator of OIRA, to agencies a couple months ago, which was a little unclear, but seemed to suggest that going forward, OMB is going to be setting the regulatory budgets for the agencies, and they're actually going to set them below 0, so that the costs imposed have to be negative. So any new regulations that you want to issue that impose costs, you actually have to take deregulatory actions that make it so that the net cost to business goes down over the course of the year. There seems to be little acknowledgement or appreciation of what other speakers have talked about today, is that you can't just take regulations off the books. It's not that simple. It is a longer process. It's unclear whether they don't quite realize that, or they do realize that, and that's sort of the point, is that it because you won't be able to do that, it makes it very difficult to take new regulatory action. So I want to talk about why this is problematic for health, and I'll bridge back a little bit to public health, since that's my focus, but I really want to focus in particular on the FDA, which is kind of an intersection of public health and healthcare. And just a quick disclaimer on this. The administration has been sued over this executive order by a bunch of public interest groups. Public Citizen is the lead plaintiff in that case. And my wife, Rachel Blumkatz, represents public health groups that have filed an amicus brief in that particular case. So I just wanted to acknowledge that connection, and also note that she's helped me look at some of these issues, so she gets some of the credit and all the mistakes are mine. A number of things that are troubling about this executive order. So first of all, in the regulatory budgets, the way that I've tried to explain them, the budgets are based only on the costs that are imposed on regulated entities. The benefits are not considered. This is not a cost-benefit analysis where you're looking at the costs and weighing them against the benefits. You are only looking at the costs. Agencies are specifically instructed not to consider the impact on health or public health. They're only looking at the costs. So this is deeply problematic. To just use one public health example to illustrate the point, I work in the area of tobacco regulation for the most part. The FDA actually issued a proposed rule a week before this executive order came out. The proposed rule was addressing a carcinogen called NNN, N-nitronornicotine, which is a carcinogenic component that's found in tobacco naturally, but the rule addressed smokeless tobacco. And it was a very simple rule saying that smokeless tobacco companies had to take actions to reduce the amount of NNN in smokeless tobacco products. This is something that is technically feasible to do. There are similar rules in other countries. Tobacco companies can comply with this. They can do this. We know they can. And the FDA estimated in their cost-benefit analysis that doing this would avert 13,000 cases of oral cancer over the next 20 years. It would prevent at least 2,000 deaths over the course of the next 20 years. The overall economic impact, when you balance the compliance cost to business against the public health impact, would be a net gain, a net benefit of $15 billion. I worked at the FDA for a while. The FDA's cost-benefit analyses, in my opinion, are extremely conservative. In this particular one, the benefits only looked at oral cancer and didn't even look at the fact that reducing NNN also would reduce esophageal cancer, pancreatic cancer, other types of cancers. So I think that's clearly an underestimate. But regardless, for purposes of this executive order, the FDA can only consider the costs imposed on regulated entities and none of those actual benefits. And if it were actually going to issue the rule, they would have to offset those costs by repealing other rules. So it's of course now unlikely the FDA is going to finalize that rule. If they did, it is unclear how they would identify other rules to eliminate. And I raise this one because this is not the most kind of ideological, controversial rule. You're taking a deadly product and making it a little less deadly. Tobacco companies are opposed. Other than that, this is a rule that has extremely broad support. So, and I should mention too, any rule that is out there by any agency has gone through a cost-benefit analysis, and the agency, by definition, has concluded that the benefits of that rule outweigh the cost. So, taking rules off the books is difficult in part because you'd have to overcome the fact that the agency has already justified this rule with its own cost-benefit analysis. Just a quick aside, one of the kind of surprising things that the Trump administration has done is that the FDA administrator, Scott Gottlieb, suggested that they would like to, or that he wants to look into making cigarettes non-addictive. There is, in terms of a regulatory action, very few things that could be done that would have a greater public health impact than that. I'm highly skeptical that it's going to happen under this administration, but again, if you actually were going to go through the process of the FDA doing that, they would only be able to look at the costs for purposes of this regulatory budget. They would have to identify two other things to knock out. It makes it extremely difficult for them to do it. So one problem with this is the way they think about costs. Another thing is that it all the things that the FDA has been working on for years that were in process, it is extremely difficult for them to finalize. And sort of related to that, they can't update regulations that need to be updated. So just to give a couple quick examples, one example is the FDA has been working on regulations for a while to move towards electronic packaging inserts instead of those like little tiny inserts that are in your medication boxes that no one actually reads because it's in like 2-point font. The idea is to move towards electronic ones so that at least providers and pharmacists will have easy access to that, and more importantly for health, when things change, they can be immediately updated, and so you're not looking at information that is no longer accurate. The pharmaceutical industry has been supportive of this, but even a minor rule like that is an economically significant rule because really anything that touches the healthcare sector is going to be an economically significant rule. So even things like that again don't have a strong ideological partisan valence that industry is supportive of, are going to be really hard to get through. And it's worth noting that in many contexts, including but not limited to healthcare, businesses often welcome new regulations because they provide needed updates, because they provide clarity, they tell agencies what they need to do. Sometimes they offer safe harbors that let them know that if they follow the regulations, they'll be protected from being prosecuted for legal violations. Also, I mean, one of the most important purposes of regulation is that they level the playing field. If there are sort of bad actors out there that are acting in unscrupulous ways that undercut the market, that puts pressure on the rest of the industry to do the same unless there are regulations and regulatory enforcement. Last point on this executive order, it applies even to new mandates that have just been issued by Congress, and this sort of bridges me into talking about the legal pieces for a minute. So, example of this, the 21st Century Cures Act, which was passed at the end of the last administration, requires the FDA to do a lot of restructuring around the drug approval process. In many cases, again, these are changes that the pharmaceutical industry asked for and was strongly supportive of. It's now unclear how much of that they'll be able to do, again, because really anything that touches on healthcare and the drug industry in particular is going to be labeled as an economically significant rule. So those are some of the bigger picture issues. Just to mention the legal issues, as I mentioned, Public Citizen filed its lawsuit. It has 3 interrelated legal claims. One is a kind of generalized separation of powers claim that essentially the executive order here is overriding the instructions of Congress. Congress has given instructions to these agencies about what to do, and this executive order is overriding that. Whether that's something that's judicially actionable, we will see. Second, kind of related, is the Take Care Clause claim. The idea here that the administration has a duty to faithfully execute the laws that have been issued by Congress. Again, this is an issue that has not come up too much in the past, but is probably going to come up a whole lot in this administration, and it'll be up to the courts to decide whether that's something they want to adjudicate. And then third is the Administrative Procedure Act, and the argument that essentially this executive order is instructing agencies to violate the Administrative Procedure Act by taking into account factors that are improper considerations and essentially make the rulemaking process arbitrary and capricious under the Administrative Procedure Act. So we'll see what happens. The hearing was held in August in this case, and it's Public Citizen versus Trump if you want to look at it. No rulings yet, but that could really come any day. So the effect of this order is to really stop rulemaking across the federal government. It was raised on a previous panel that perhaps we wouldn't really expect that much rulemaking to come out of this administration anyway. I think to some extent that's true, but to some extent that isn't. And that's why I've tried to use some of the examples that I've used here. That, I mean, there are long-term initiatives of a lot of federal agencies that aren't particularly ideological, but some of them are actually important. And all of those are going to be ground to a halt as well. So a few, I'm running short on time, so a few kind of bigger picture points to take away from all of that. One is that this executive order and a lot of what this administration has done frames regulation entirely negatively. The whole sort of structure of this executive order is that regulation is something that imposes costs, and the benefits are not even something that we consider. That's been a push of Republican politicians, to be blunt, for a long time to sort of talk about the overreach of the administrative state. It is not something where Democrats have really pushed back on. You don't see people going out on the campaign trail talking about the great things that administrative agencies do all that often. Because of that, I think responding to that is challenging. Secondly, it makes rulemaking, this is sort of an additional thing that makes rulemaking a lot harder, and this is where I just want others to mention as well. It ties into a history of pushing deregulation by making the rulemaking process more complicated and more difficult. It started with the Reagan administration. A lot of sort of processy things were put in place to gum up the works. This whole idea of cost-benefit analysis came out of that era, that context. The Paperwork Reduction Act, the Data Quality Act. There were sort of a lot of things that were added on top of that. And that's really continued to build under administrations of both parties, to be honest. And then third, this executive order kind of increases the consolidation of power by the Office of Management and Budget, OIRA, the White House, over the entire regulatory state. This concept of the regulatory czar, Cass Sunstein in the Obama administration sort of welcomed that title. It's actually a relatively new title. This isn't the way that it used to work. It's really started to some extent with the Reagan administration, more in the George W. Bush administration, more in the Obama administration, more now. So those are some of the big picture plans, or sorry, big picture concerns. Just kind of final thought is that, you know, as it gets harder to pass anything through Congress, those few things, sort of putting reconciliation aside and that mess, those few things that do get passed through Congress tend to be the things that have strong bipartisan support behind them. They also tend to punt on any difficult questions, because the easiest way for Congress to decide on something is to decide not to decide and just punt those issues to administrative agencies. And if you really have agencies that are unable to get anything done, and you have a Congress that is virtually unable to get anything done, then truly nothing happens, and I think we're in a really problematic and dangerous place. Thank you.
Pull up the slides. All right, so while I have some help pulling up my slides, thank you so much again to UC Hastings for all of you for sticking it out. That was a really terrific lead-in by Dr. Bindman and by Professor Berman, and we are really, you know, this is a great audience. So I just wanted to say I'm going to be talking about something that is tough even for lawyers, which is ERISA preemption. So I sort of ask your forbearance because I'm going to try to make it interesting and accessible, but we'll see. Well, I'm just going to apologize in advance for that. So I'm going to be talking particularly about the deregulatory effect of what's called ERISA preemption, and I will explain what I mean by that, in the context of state attempts to regulate their own healthcare markets, because as we just heard, there is little to nothing forthcoming out of the federal government in terms of new affirmative regulation. And so this is creating an increasingly important and large role for states in terms of healthcare regulation because of the inaction at the federal level. But there's also, paired with that, as we heard about today repeatedly, this affirmative policy preference that states should have more flexibility for the role of federalism, as it's called, to give states more responsibility over their own, you know, managing their own affairs and giving them the flexibility to do so. So we saw a lot of this come up, for example, in the ACA repeal bills, which all featured versions of states get more flexibility, states get block grants, or states get waivers. So we're seeing this play out. But in fact, states have become, in reality, the locus of much healthcare regulatory innovation, and the action in healthcare is really happening at the state level. So what I'm talking about today is this claim that states have been passing robust healthcare, particularly consumer protection and transparency laws. That's what I've been doing research on. But the problem is that there is this federal statute called ERISA, and it has a very broad preemptive effect on state laws. And ERISA's growing preemptive sweep means that all of these state innovations can't reach a very large proportion of the population that is supposed to be protected by these state innovations. Because of this lawsuit and this case that was decided by the Supreme Court last year called Gobey versus Liberty Mutual, after this decision that expanded ERISA preemption even further than it was interpreted before, for these state consumer protection laws to reach everyone, we actually need a federal solution. So what do I mean when I talk about ERISA preemption? So ERISA is the federal law that governs all employee benefits, including employer-based health plans. So ERISA is very it's unique in how broad its preemptive provisions are written into the statute. And so for the purpose of state health care protection and state health care regulation, what I'm focusing mostly on is this provision of ERISA that's under Section 514 of ERISA, which expressly preempts any and all state laws that relate to an employee benefit plan. So there's an exception for state health insurance regulation, which is saved from preemption by what's called the Savings Clause of ERISA. But then there's an exception from the exception in the Deemer Clause, which then says that there is basically that express preemption does apply to what are known as self-funded or self-insured employee benefit plans, which are not in the business of insurance. Meaning that if your employer keeps the financial risk for providing health benefits to its employees, then that employee benefit plan is not subject to any state regulation. So the upshot is that state laws that relate to or impose requirements on employee health plans are preempted if the law either doesn't regulate insurance or relates at all to an employee benefit plan that is self-insured. All right, so what does that mean in terms of the proportion of the population? So among the non-elderly population, that's the big circle, 56% of the non-elderly population is covered through an employee benefit plan. And of that sort of 56%, 61% of those are covered by self-funded health plans. The other remaining sort of 39% are covered by what are called fully insured plans. So what that means is about a third of the non-elderly US population is covered by a self-funded ERISA plan that is untouchable by state regulation. So why do we care? Well, there are three state sort of laws that I'm going to focus on just as exemplars, but this reasoning actually extends beyond these three. I'm going to illustrate how ERISA preemption thwarts a range of state healthcare innovations, and I'm going to talk about all-payer claims databases, drug price transparencies for pharmacy benefit managers, and surprise out-of-network medical bills. So all-payer claims databases are large-scale state-run databases that collect healthcare price and quality data from all the payers in the state. So importantly, they collect the amounts that the payers paid for those services. And so this is otherwise almost totally inaccessible and opaque to consumers and to regulators. It's almost impossible to get this data otherwise. So 18 states have established or are implementing APCDs, and they form the foundation for the most robust tools for healthcare price and quality transparency for consumers, but more importantly, I think in some ways, also for state regulators who need this data to know what's going on in their markets and to know whether they have a healthcare price or variation problem in their state. So what happens, though, is we had this case, the Gobet versus Liberty Mutual Insurance Company case of 2016, which held that Vermont's APCD reporting requirement was preempted with respect to ERISA plans. And so I have an asterisk there because that's, the holding didn't actually mention self-funded ERISA plans, but the Supreme Court didn't have to address that issue because Liberty Mutual was a self-funded plan. So it didn't even get to the question of whether or not the Savings Clause would allow reporting by fully insured plans. So the court reasoned that preemption was necessary to prevent states from imposing inconsistent and burdensome reporting requirements on ERISA plans, which according to the statute must be subject to uniform national schemes of administration. So of significance for state healthcare, consumer protection, and transparency laws, the court held that reporting and disclosure, just the act of reporting and disclosure, are central functions of plan administration, which means that any state law that requires a health plan to report or disclose any data of any type would be preempted by ERISA. That's any state healthcare transparency law that applies to plans. So we saw this play out with drug price transparency. So there's a widespread lack of drug price transparency, particularly surrounding the middlemen known as pharmacy benefit managers. These are the entities that go between the manufacturer, the health plan, and the pharmacy to create, the covered drugs on a formulary. And so states have pursued policies to gather information about the drug prices, the markups, and the rebates that are in this sort of black box of negotiation between the pharmacy benefit manager and all of these different entities. In fact, there were, in the last two legislative sessions, there were 24 bills introduced across 13 states just aimed at shining a light on pharmacy benefit manager pricing policies. However, PBMs do administer drug benefits for ERISA plans, including self-funded ERISA plans. So just, early this year, there was a decision in the Eighth Circuit, the Gerhardt case, in which Iowa's PBM transparency law was preempted by ERISA. What the Iowa law required was for PBMs to report their drug pricing methodology to the state insurance commissioner. And the Eighth Circuit, all it had to do was just apply the Gobet decision, didn't have to do really any sort of, analytic steps along the way, just took the reasoning and applied it to this situation and concluded that because disclosure and reporting are central functions of plan administration, that because PBMs administer drug benefits for ERISA self-funded plans, that would be preempted by ERISA. So the consequence here is that state drug pricing laws that are directed at PBMs are preempted if the PBM administers benefits for self-funded ERISA plans. So the last example I'm going to talk about briefly is just something called surprise medical bills. Surprise medical bills are those bills that arise when an insured patient involuntarily and inadvertently receives care from an out-of-network provider. So typically this could happen in an emergency, or if the facility happens to be in network, but one of the providers involved in care is out of network, say the anesthesiologist involved in your surgery. So a handful of states have passed laws that affirmatively protect consumers, California being one of them, and patients from the financial burdens of surprise medical bills. And so the states require disclosure of the provider's out-of-network status, the consequences to the patient, and require the patient to basically choose and consent to the out-of-network service before being charged any sort of additional costs. So some states go further and prohibit charging patients for any surprise out-of-network cost sharing or balance billing. California's law does this, and also require plans to hold members harmless, meaning it's the plan's responsibility to pay your out-of-network bills, not the patient's responsibility, and reflect those rights in their plan terms, apply any surprise billing amounts to in-network deductibles, in-network cost-sharing limits, and all of these financial protections that end up being very serious for healthcare consumers. So to the extent that these requirements are directed at health plans, not just the providers, these state laws basically would be preempted by ERISA for the same reason that we were talking about earlier, especially with respect to self-funded plans. So in other words, even if you live in California and the state passes a protection against surprise medical bills, if you have self-funded employer-based coverage, the state protections that are mandated on health plans wouldn't even apply to you. And you wouldn't even know it, because the irony here is that whether or not any of these state laws apply hinges on whether your plan is self-insured or self-funded, which is itself usually completely opaque to consumers. And you can ask yourself, do you know whether your insurance is self-insured or whether it's fully insured? You still will get the card from what looks like an insurance company, from Cigna, Humana, Blue Cross, whoever, who administers your network, who administers your claims. To you, it looks like you have insurance, but you may have self-funded insurance, and that may just be its third-party administrator. So all of this means we need a federal solution, because expanding the breadth of ERISA preemption means that there's nothing really the states can do to get around ERISA preemption. Any form of disclosure, reporting, consumer protection law that imposes requirements on health plans are going to require something from the federal government to get around the ERISA problem. So the first option is to seek federal regulations from the Department of Labor, which regulates ERISA plans. And this would probably entail seeking issue-specific rules for each set of these issues. So for example, the ACA's insurance rules might allow some data reporting on claims data from ERISA plans. But there is an open question whether Department of Labor has sufficient statutory authority to promulgate federal standards in each one of these substantive areas, which, as we're learning about from an administrative law perspective, agencies can't just act without statutory authority. They have to act within the limits of the confines of their statutory authority. So this is what I'm calling the ERISA black hole. If the Department of Labor doesn't have statutory authority to regulate, then no one, not the states, nor the federal government, can regulate self-funded ERISA plans. There's no one who can act. And so, of course, this all assumes that there is a Department of Labor who's willing and able to promulgate rules, which after Micah's presentation, you're, I'm sure, not very optimistic about. And this deregulatory posture of the Trump administration means that all of this sort of theoretical regulation would be highly unlikely. So what's the second option? Also somewhat or highly unlikely. It's to go to Congress and amend ERISA. So the second option would get seek a legislative amendment to ERISA, and it could be structured broadly or narrowly to carve out these types of laws from ERISA preemption. And one option would be to replace ERISA's broad any and all preemption with something like the preemption that we see in HIPAA, which is a floor preemption. The federal government can set a federal minimum standard, but states are still permitted to sort of layer on additional non-conflicting requirements if they want to. That is not permitted under ERISA preemption. It doesn't matter whether it conflicts with federal law, it's preempted if it's under ERISA's preemption scheme. So this option, of course, raises its own questions of political will, because ERISA is itself protected by entrenched interests of large employers and the third-party administrators who administer the plans. But a lot of this political rhetoric that we're hearing in healthcare in particular centers on increasing state responsibility, on increasing transparency, on increasing consumerism and skin in the game. So to the extent that ERISA is thwarting the expansion of state flexibility or consumer principles, then perhaps there could be an opening for some support for a modest change to ERISA to undo the Gobet decision. What can states do in the meantime? What if there is no federal solution, the more likely scenario? States can focus their efforts on requiring disclosure and reporting from non-ERISA entities, so providers. So I'm sure providers are going to love that they're going to be the ones bearing the burdens of all of this compliance. Manufacturers of drugs, non-ERISA plans like state employee health plans or non-group plans, the individual market, Medicaid, et cetera. Second, states really should encourage and incentivize voluntary participation by self-funded plans by showing these employer purchasers what's in it for them. So for example, a lot of employers are interested in identifying who are the low-value, high-cost providers and avoiding them in their plans. And so that would be something that these, for example, APCDs could help provide to employers. And then finally, there was a post-Gobet case in the Sixth Circuit that opened a crack in the preemption edifice, and that case held that their states may require incidental reporting of a little bit of data as part of a state tax on a self-funded ERISA plan. So you can still tax a self-funded ERISA plan, and if you do tax them, you can ask them to submit a tax return. You can't probably get all the APCD data in that tax return, but you could probably ask for something. And so states are maybe going to have to look at what they can do pursuant to such a tax. Probably most relevant for this conference is that the breadth of ERISA preemption naturally involves some trade-offs. So it's often framed as a choice between national uniformity on the one hand for multi-state employers versus state flexibility on the other and federalism. So right now, all of the sort of weight is tilted heavily toward national uniformity. And other than politics, it's not entirely clear why, as a policy matter, this is necessary or preferable to allowing state experimentation. Employers still have lots of incentives, namely the favorable tax treatment of health benefits, to offer these plans, yet some costs obviously will accrue to employers and employees to comply with, myriad state laws. So there are sort of cost trade-offs, but what I'm pointing at is there are costs to the existing sort of state of affairs as well. And maybe the real trade-off is between deregulation versus regulation and consumer protection. The typical justification for deregulation, or one typical justification, is let the market address the problem. And that is just not an available defense here. The consumer problems that state regulations are trying to fix are driven by widespread market failures, lack of information, lack of competition in the marketplace, consumers' inability to really act like consumers and make choices that reflect their preferences. All these monopoly conditions, these principal agent problems, information asymmetry means that you can't get around it simply by letting the market do its job. So, in sum, the states really have been the legislative innovative engines for healthcare consumer protection and transparency. And after Gobet, though, the ERISA vacuum has expanded. It's now starting to resemble a black hole that's consuming an increasing swath of state health and safety regulation. And that means a federal solution is needed. But even if there is political will at some point in the future to craft a federal requirement, it should really be done to the greatest extent to preserve state flexibility and experimentation. We are seeing really good experimentation happening at the state level. And where the standard, this suggests that the preferable federal solution would be to amend ERISA to allow sort of the state types of flexibility that we see with floor preemption. And with that, I'm going to stop, and we will save time for Renee's presentation.
I feel like I've learned a lot of information in this past 45 minutes, and so it's also been quite depressing for me to have it explained in such clarity. So I feel like usually the fourth last panelists should be somewhat uplifting. And the only thing I can say is that perhaps our healthcare system will deteriorate to such a point that people on all ends of the political spectrum will require or demand radical transformation. So that is perhaps our only hope. To just talk about deregulation a little bit, I want to just put our healthcare system in context, in the global context, and just to talk about the fact that most of the industrialized countries in the world, of those, the United States is already quite deregulated. And when I talk about that, I'm using the perspective of looking at financing and delivery. So when we think about public delivery and public financing, that's what the way most or many countries, industrialized countries in the world, do healthcare. So they have public financing, meaning there's a public way of paying for care, and there's public delivery, meaning that the people who deliver your care are part of the government, and it can take different forms, but generally that's how it's done. There are different hybrids, of course. Germany has public financing and a lot of private delivery, and Canada has a mix of both. But in the United States in general, we have financing is mostly private. Medicare and Medicaid are public, but then delivery is almost entirely private. There's always exceptions, of course, the military and the VA, but already on the spectrum globally, we are already quite deregulated. And so that's just something that I think is important for us to know in terms of context. When I talk about the United States in this just next kind of 15 minutes, I want to provide you a perspective of what is the empirical evidence that we have of the way our current healthcare system is, and what are examples of how regulation has changed our system and deregulation may change our system. And also give you a little bit of kind of the clinician perspective of someone who sees patients every day who come into the emergency department seeking care. So I'm going to use the lens of cost and quality and access, since that's something that the Institute of Medicine, or now the National Academy of Medicine, often uses when we look at our healthcare system. But I also want us to think about the idea of choice, which is very American and something that I think is driving a lot of this move towards deregulation, because as Americans, we want to have a lot of choice, and that's just kind of who we are. And I think it's important to incorporate in our discussion of what we want as a society, because healthcare and the way we deliver healthcare is very much a construct of what our values are. So when we look at that, I'm going to first talk about access, because I think that's a really important way to look at healthcare. And what do we know already from the way our healthcare system exists in terms of access to care? So we have very good data, and this is a lot of what I spend my time when I'm not working clinically in the ER, is actually looking at access to emergency services from all patients, but especially patients who are vulnerable, so those who are poor or don't speak English. I published a paper in JAMA in 2011, the Journal of American Medical Association, looking at the risk factors of what makes you as a hospital more likely to lose your emergency department. So basically looking at a survival analysis at the hospital level of hospitals whose ERs die. And what we found wasn't super surprising. We found that hospitals that have lower profit margins, hospitals that treat poor patients, hospitals that treat patients who have bad insurance, which is considered uninsurance or Medicaid. I should qualify that, but poorer reimbursement compared to private and Medicare, had a higher risk of dying, of losing their emergency departments. My brother, who's not in medicine, found that, and this was published in the New York Times, it was published in JAMA and the New York Times covered it. My brother was like, he was like, I could have just told you that. It's not rocket science, But, we were one of the first teams to actually just show that, and you can look at the death rate of hospitals with emergency departments. And there is empirical evidence showing, not just in emergency service, but in all types of care, that you are more likely to lose your services if you are poor and you are covered with, not good insurance or uninsured. And what are the effects that this has actually on patient outcomes? So when you think about it, just logically, you could understand. I just had a patient last week who came in with a stab wound, and it was actually pretty stable. And then we put an ultrasound on his heart, and you could actually see the blood in his pericardial sac, which is the sac that holds the heart, which actually should not have blood in it. The heart should have blood, but not the sac. There was actually blood going into the sac out of the heart, and you could see the heart getting smaller and smaller and smaller. And had we not been there, and had he not come to the trauma center, I can guarantee you that his outcome would be totally different. He probably would not be here today. And that's what happens, on a large scale. And so we actually can show this empirically as well. When you have a closure in your community, and you have to drive further to the next emergency department, and we published this in Health Affairs last year, you have a higher risk of dying, all things being equal. And that should be compelling evidence. This doesn't just happen in emergency departments, it happens all across the spectrum. So not just in ER services, but even in ambulance services. So we find, and this is a paper that's in submission now, but if you are in a poor area, it takes longer for ambulance services to get you. And we know that this is happening over time because ambulance services used to be something that we all considered as a public good. We just assume when we call 911 that we're going to have a public service, that's what our taxpayer dollars pay for, and that we should have equal access. But increasingly, this is actually becoming something that venture capitalists and private equity is starting to take over healthcare, and even in emergencies in ambulance services, which is a little bit shocking to some people, and even, but you could argue that maybe they do a better job, maybe they're more efficient, but what we have found so far is that there is increasing disparity. So if you are in a poor area, it takes longer and we looked at patients with cardiac arrest. This isn't just patients who are calling because they want to ride downtown and they don't have transportation. This is people who are in cardiac arrest and it takes ambulances longer to get to them. Another example, which I just think this statistic is important to kind of think about, to put things in kind of context, is so PCI is percutaneous coronary intervention. So if you have a certain type of heart attack, we know that it is better to get to a hospital that can have certain services to kind of open up, put a balloon in your coronary arteries, and it has a better survival outcome. So PCI services, percutaneous coronary interventionary services, have become increasingly available over the past 10 years. So over the past 10 years, there's been a 44% increase in the number of hospitals who can do PCI. But the percent of the population that is actually increased access to is less than 1%. Because they're all happening in the same places. It's all hospitals that are in kind of more affluent areas opening up PCI labs to patients who already have access to the service because they're competing for patients. And that's not a great use of our resources, and is an example of how access is becoming worse for certain parts of the population and maybe getting better for others, but it also leads us into the question of quality. So we've already talked about this access piece, but this part about quality I think is important because I remember when we published that article in JAMA in 2011 and the New York Times reporter, she said, Dr. Hsia, it's unfortunate that poor people have less access to ERs, but how does this affect Times readers? And I can understand the thrust of her question because she's trying to get to her, reader base. But it made me think, it's really important to think about people generally will look at these results and say, well, that's just America. The have-nots just have less, and the rich people just get richer. And so is it possible, though, that when you have this redundancy in the healthcare system, that quality actually becomes worse for those even who have? And I think that there's evidence to show that because there's good research showing that there's something called a volume outcomes relationship, meaning that the more you see of a certain condition, the better you are at treating it. Now, if you have all of these hospitals in these affluent areas now becoming PCI centers, but you only have a fixed number of heart attacks, you just can't increase them even if you would want to, then you have the number of operators who are actually doing these procedures just gets diluted. And you could see that it's potential that quality also becomes worse, not just for those who don't have, but those who have too much. And so I think that's just an important lens because we might not often think of that, but there's a lot of data when you look at different studies showing that too much healthcare can also be bad. And so I just want to bring that perspective in because I've seen that as a patient and as a provider, and I think you all have as well. The last part I want to talk about is when we talk about cost, is we like to think, and Erin talked about this a little bit, that, Erin talked about market failure, and I think this is an important part about cost, because we like to think that the market can take care of all of our ills. But there's good reasons why healthcare may not fit perfectly into that box. And one of the reasons is information asymmetry, which is just a fancy term for saying that you don't have enough information to know the consequences of that choice. And so I'll give you an example of why cost is, when you just look at basic data, I'll just actually share a story. I think it'll be a little bit easier to illustrate. So I had a friend a few years ago, and this is not HIPAA violation. It ended up getting covered in quite a few papers. But the way it started is I ended up publishing this research letter. He called me, he's a friend from church, and he emailed me and he said, Renee, I got hospitalized for appendicitis, but the hospitalization for the appendicitis was $53,000. He's privately insured. He works in finance. He said, my insurance company paid $23,000 and they're balance billing me for the rest of the 30. He said, I want to be a good citizen and I want to pay my bills, but what's a normal price for an appendicitis? And so I just looked in the data that I had, and was not a difficult study at all. It was just very descriptive. And we found that for patients, healthy patients, 15 to 44, who had a normal, like 3-day stay, discharge home, uncomplicated appendicitis, what's the range? Like how much, was it a big range, little range? Like what's the just average price? And we found that the lowest price charge was $1,500, and the highest price charge was $153,000, with a median price of $33,000. And so it's just not something that as a patient, you would be able to say, look up on the web, let's just say, what is this hospital going to charge me for this? And because there's so much information asymmetry, you don't know how long you're going to stay on the hospital floor. When you go in, you're not coming with a diagnosis of appendicitis, it's abdominal pain and nausea and vomiting. And there's just too much information that you don't have to be an informed consumer. And I think there is this movement towards trying to becoming, we want to empower patients with more information so they can make choices, because we are all about choice. But I think we need to ask ourselves, when we talk about choice, do we really have choice if it's less access and less quality and when costs aren't really controlled? And so I think that might be, I do want to provide a little bit more facts, which I think are just important to also keep in mind. When we talk about cost, it's not just cost to ourselves, but when we talk about cost to the system. Steffi Woolhandler had a paper in New England Journal of Medicine, which is really dated. It's 1991, but it's actually probably even worse now. But she looked at the insurance overhead of our system and Canada's system. And our system, in terms of insurance overhead, has about 11% of all premiums goes to overhead. And in Canada, it's just 3%. And when you think about it, even as a provider, when I have to do my coding and it goes to a third party to do coding, these coders have to take your chart and they have to put your claim on the form of whatever patient's insurance company it is. And every insurance company is probably going to have a different form. They all have different rules about what kind of coding they want. They send it over, they reject it, then you need to send it back because they have different rules about which things qualify. I think this is a great way of creating jobs, but probably not the best way of providing good healthcare. And so I think it's just another perspective to think about when you actually, also in that paper, which is an interesting paper, she counted the number of managerial clerks and staffs in a certain office compared to the actual number of technicians and technologists who are providing healthcare. And it actually outnumbers the number of managerial staffs and clerks that you have doing that outnumbers the people actually providing care, which I think is also just a little bit compelling to think about. And I think the last thing that I'll probably just share with you is when we talk about access, and I remember this vividly in my mind because this was a patient who came maybe it was 10 years ago, but it was when I started my training at SF General. And he was probably an undocumented farm worker who came to California with the promise of housing and work, but he actually didn't get the housing part. And so he was sleeping outside in Central California, and he would, pick whatever it was during the day. And then at night, one night, he got attacked by a pack of wild dogs. And he came in, I will never forget it, just all parts of him were mangled and his ears were bitten off and just parts of his muscle were detached from his body. And, these are the people, he didn't have care there. So they took an ambulance all the way to San Francisco from, I don't exactly know where he was in Central Valley, but they didn't have a trauma center. And I don't want you to think I'm saying you need a trauma center on every corner, because that's also not the best use of resources. But that's the kind of experience that patients have when you don't have emergency services. And we have enough data to show that when you allow for no regulation, for hospitals to just do what they want with their services, there's actually no mandate for hospitals to have an emergency department. And we know from literature also that for-profit hospitals behave very differently from not-for-profit hospitals and government hospitals, and that they are more quick to cut service lines that are non-profitable, such as emergency services, HIV services, and they're more likely to adopt profitable ones, such as dermatology and cardiology, and that we will continue to see these types of exacerbations in this line of haves and have-nots, which also has effects on those who have, if we continue to allow deregulation to take form.
Okay, I have a few questions, but I think I'm gonna open it to the floor because we have only a little bit of time left. So, take questions from the floor.
Everybody.
Yeah.
Is there currently a law that requires, like in San Francisco, say 30 years ago, some fancy some community panel or some kind of a panel to decide whether 2 hospitals could have some kind of specialized equipment. And is that law out the window?
In California, it is. Yeah.
Yeah, so what you're referring to, what used to be referred to as certificate of need type regulations, and we live here in the Wild West, and that's long gone. Basically, those who were selling competitive models said that that wasn't the way to go. There are still some states that do that. Maryland is probably the most often talked about and studied in terms of being much more kind of a planning mentality as opposed to letting the marketplace solve these things. Right. Yep.
And I live in a certificate of need state, Georgia, and I practiced here in California, and but the problems are the same. I mean, we're having hospital closures, there's lack of access. It's certificate of need doesn't ensure that every community has needed services. It actually is just mostly used as a way to prevent competitors from entering the market.
Yeah, Andrew.
The idea of kind of giving states flexibility, the assumption that they will actually innovate if you give them the flexibility. I'm curious whether, in looking state to state, whether you're seeing what's driving some states to innovate, and I suspect there's a partisan nature to it as well as kind of state capacity. So in other areas of reform, I think capacity is very important. So I'm curious in the legal sense of the states that are doing it, what's driving some of the variations you're seeing in terms of states that are proposing and enacting these state level.
I think there is somewhat of a partisan valence, but not entirely. So, for example, of the 6 states that have passed surprise billing laws, the 3 strongest laws I would characterize are from blue states like California, New York, and Connecticut. But Arizona most recently passed one, Florida passed one, and Texas has sort of a minimalist one. And so it's not entirely based on partisan efforts. And things like all-payer claims databases, again, 18 states, not entirely states that are sort of highly regulatory. But you do see, that's one of the drawbacks of sort of letting the laboratory of the states be the sole backstop for lack of federal action, is that you're going to have states like the one I live in that'll never regulate, that won't adopt Medicaid, that won't expand Medicaid. I mean, it won't do any number of things, partly from a capacity standpoint, partly because of a political standpoint. But I think to me, what I've seen work best is a model where there is a sort of federal standard, that there is sort of, that we learn from state experimentation, what ought our national standard look like? And then you adopt a federal standard, and then states that want to go further can, but there still is that federal floor for the states that don't do enough, that don't really take it up. And so I think that's sort of the back and forth. That's when federalism really works, not when the federal government just steps back, does nothing, and then, the blue states do stuff, and then the red states don't do anything. But
Yeah, I can't help but jump in here, and you would probably comment it better, but I mean, I think we're seeing under this administration, a lot of the flexibility at states happens at Medicaid programs, and some of the things that actually allowed us to get to the ACA had to, you required a Medicaid waiver in Massachusetts to make that state possible as an innovation that ultimately led to a national change. Well, now we're hearing from the Trump administration, they want to turn Medicaid programs into Indiana, where basically Indiana was a state that came up with the ideas of, to get Medicaid, you had to be working, you had to go through all sorts of hoops and barriers. Instead of it being an entitlement based on poverty levels, it now comes with all these conditions. And the Trump administration has signaled very loudly that it would like to see that become the mode for Medicaid programs across the country. So state innovation has its positive sides and also can be used as a axis of evil, I guess.
And the administration is by no means consistent on the issue of state innovation either. And so, I mean, the Medicaid example, if you haven't read Seema Verma's speech from a week and a half ago, you should. It's remarkable. But on the flip side, Massachusetts applied for a state innovation waiver to basically protect themselves from the cost sharing reductions, and it was denied. They were not given the flexibility to do that.
I actually think we're over time, but for those of you who have questions left, please come up and ask the panel. I'm sure they'll stick around for a minute. So please join me in thanking the panel for such a good time.
Okay, I'm John Crawford. I'm a professor here at UC Hastings focused on financial regulation, and I'm here to bring you the financial regulation panel. The period between 2010 and 2016 was probably one of the most fecund periods in history in terms of rule writing in the financial regulatory sphere. I think by one measure, there are close to 30,000 pages in the Federal Register just filled with rulemakings pursuant to the Dodd-Frank Act. And that's probably more impressive to those of you who've seen the Federal Register. So when the election happened last year, there was some noise about a potential legislative rollback. That hasn't happened, and I think probably consistent with a lot of the other regulatory or deregulatory action in the other areas that we've been talking about, it's been much more death by 1,000 cuts. And to that end, I wanted to read a very short paragraph to you all. If you all are interested in this area at all, the best piece of advice I can give you is to read Money Stuff, which is the daily newsletter written by Matt Levine at Bloomberg View. He's, in my opinion, the best financial journalist working in English, and he's often kind of funny. And this was the opening paragraph from yesterday. He said, "There have been a lot of stories recently about how the U.S. government has kind of given up on financial regulation. This week, the Senate moved to limit strict Federal Reserve oversight and stress tests to just the dozen biggest banks. That was down from 38 banks. There's a story about how the Office of the Comptroller of the Currency has gotten much laxer on a range of mostly consumer protection. There's a related story about how Mitsubishi UFJ Financial Group is trying to get regulated by the OCC, the Office of the Comptroller of the Currency, rather than by the New York State Department of Financial Services, presumably because it expects the OCC to be gentler. And that, by the way, was in the middle of an investigation about noncompliance with various rules that banks are supposed to follow to ensure that their customers don't violate sanctions placed on other governments. Yesterday, Richard Cordray announced that he will step down as the head of the Consumer Financial Protection Bureau, presumably to be replaced by an ashtray or a block of wood or Eric Trump. Today, we learned that the likely replacement, at least, and this is not a joke, on a temporary basis, is Mick Mulvaney, who's the director of the Office of OMB, the Office of Management and Budget, who will be keeping his day job and has publicly called the CFPB a sad, sick joke. And justice investigation into Russian laundering through Deutsche Bank gone quiet. None of these things feel like blockbuster structural changes to the U.S. banking system, but together they represent a pretty big lurch of the regulatory dial toward deregulation. I thought that was a pretty good description of the lay of the land in somewhat colorful terms. So our panelists today are Erik Gerding, professor at the University of Colorado, who's going to lead off and talk about ways in which financial regulation differs from other areas of regulation. Gaurav Vasisht, who is director of financial regulation at the Volcker Alliance, which is a nonpartisan group founded by former Federal Reserve Chairman Paul Volcker that's focused on good public policy generally, and they do a lot of work, not surprisingly, in financial regulation. Colleen Baker, who is a professor at the University of Oklahoma's Price College of Business, and David Zaring, who is a professor at the Wharton School. So with that, I'm going to turn it over to Erik.
Thank you to John and to all the organizers for having us here. This has been a really delightful conference to hear what people in other completely different realms are working on and how they're looking at the current regulatory climate. So I'm going to talk a little bit about how financial regulation differs from environmental regulation. My apologies to the healthcare people here. My dad was in healthcare regulation, and I think I have some sort of blockage from talking about health law. Certificates of need brought up all sorts of childhood memories of what he would talk about when he drove the state government car home in the evening. So I'm going to talk about 5 different things. One is a philosophical difference in the way in which financial regulation is different from regulation in other fields. Then I'm going to talk about how 3 reasons that financial deregulation is different than environmental regulation. And I'm going to talk about how there's a pattern that this creates of financial regulation during market booms and deregulation after regulation after market crashes and deregulation as markets boom. Important distinction. And then I'm going to talk about lessons for the next regulatory wave. At some point, the winds and the waves will shift, and financial regulation or re-regulation will be back on the table. And I think we need to think about what regulation would look like at that particular time. So here's one way in which financial regulation is different from other fields. Even Adam Smith and Milton Friedman thought there was a role for some bank regulation. Why? Because they thought it was necessary to protect against the natural instability in the basic business model of banking. And that leads to a larger point, which, and I want to thank my former colleague, Rob Schwartz, for bringing us back to a philosophical and normative underpinnings. Because here's the thing, there's no thing, such thing as a bank or a corporation in a state of nature. One lesson that we have is that a lot of legal scholars have redrawn our attention to is that law plays an integral role in creating and structuring financial markets. They don't naturally occur in the absence of any legal intervention. So when we talk about deregulation, it's a useful shorthand, I admit, for removing restrictions on financial institutions and their risk-taking. But even during a deregulatory moment, such as we're in now, we're not really eliminating regulations altogether. We're just changing the distribution among different players in financial markets. Whether it's different kinds of financial institutions, investors versus financial institutions, consumers versus lenders. Look, the real question is not sort of regulation yes or no in a sort of a CNN cable news way. It's really more of a normative question or a descriptive question even of whose ox is being fattened and whose ox is being gored. And I think this lesson from financial regulation applies to deregulation in general. Deregulation is not just a matter of efficiency, it's also distributive. And even with deregulation, in whatever field we're talking about, there's still going to be some laws and regulations that remain that favor some actors and some industries and disfavor other actors and other industries. It's again a question of who wins and who loses. All right, so here's the way in which I talked about how financial regulation is different than other fields. Here's how financial deregulation is different than deregulation in the environmental sphere. So first, there's an interaction between regulatory cycles in financial markets and financial cycles. And this is something I spent 5 long years of my life writing a book that's too expensive and no one reads. But here's the basic summary that you don't even have to spend $140 for the hard copy version. Booming markets create pretty strong pressures to loosen regulations. Market crashes in turn prompt sharp regulatory reactions. Markets and financial markets thus create a pretty strong feedback mechanism for one another. So the cycles in one sphere in markets can really reinforce the cycles in the other sphere in regulation. And that, I think, is a little bit different. We don't have market cycles in environmental law. Maybe we have them in healthcare or in other fields, but the environment has its own cycles that I don't think are connected to regulation and deregulation in the same way that we have in the financial sphere. Here's the second big difference, and I think that this is going to be really important to frame our discussion. In financial markets, there is no way to easily disentangle the good from the bad. And what I mean by that is, if you think about the environmental world, no one really wants toxic pollution. Technological change might enable us, theoretically, to get more of what we want. More power generation, more travel around the country, more manufacturing with less pollution. But technology can't easily give us more credit, more investment, more financial reward without generating more risk. At least if you buy just a very loose, even a very loose idea of efficient markets. Seeking more reward, extending more credit inevitably means more risk. It is very, very hard to disentangle those two. And that leads me to the third big difference. And I think there's some pretty strong differences in the civil society, in the players that are involved in financial regulation compared to environmental regulation. I think a playing field in civil society is much more lopsided in financial regulation than environmental regulation. In environmental regulation, we have big players. We have the NRDC, we have the National Wildlife Fund, we have Greenpeace. And we see these players being very, very active throughout the regulatory, in the regulatory space. We don't have that same size of players in financial regulation. We have some new players that are new in the last 10 years who are involved in financial regulation in terms of systemic risk and financial crises. So the Americans for Financial Reform, we have one of our panelists who's very involved in this space, but it's nowhere near the same size and scope that we have in the environmental movement. And you see this play out in the regulatory environment. So for example, Kim Kravik at Duke has had a series of articles that talks about the making of the Volcker rule. And I think we will see that same dynamic of industry having a lot more weight than groups that care about restricting financial institution risk-taking in the unmaking of the Volcker rule. And what's more, progressive groups can actually line up sometimes in favor of financial deregulation. And this goes back to the point that I made earlier, that you can't really separate the bad from the good in financial markets. So you've seen, for example, affordable housing advocates pushing for more lending at various times in American history. And I hesitate to say this because it doesn't make me very popular among some of my colleagues and friends. You've never sort of had an experience until you criticized Freddie Mac and Fannie Mae in a financial conference full of their supporters. But again, we don't like more toxins, but we do like more credit being extended throughout the country. The final difference between the civil society in environmental regulation and the civil society in financial regulation is romance. And what I mean by this is there is no romance in financial reform. And let me tell you a little anecdote. So Rob and I had some colleagues at New Mexico, and I had them over for dinner once, and I asked the two of them, you know, the standard question of how did you meet? And one colleague said, well, I really admired Reed when we were in the movement together. And I thought to myself, what? Like, there's no movement in financial reform. And that, I think, shows you sort of why civil society is so different in financial reform than it is in environmental reform. There's none of the psychosocial benefits, or not at least the same kinds of psychosocial benefits that you get from participating in financial reform that you do in environmental reform. And maybe I don't want to ask about the love lives of my co-panelists, but I'll let them weigh in on that.
Independent from financial reform.
Sorry?
Completely independent from financial reform.
Completely independent, yes. No romance. We don't enjoy any romance as a part of our commitments. So what does this lead to? This imbalance, these distinctions of why financial reform is different, particularly the intersection of cycles of financial markets and cycles in the political markets, leads to a pretty unique historical pattern. Again, where you see deregulation during market booms, followed by new regulation in the wake of a crash. Now, don't ever ask me for predictions of when the tides will turn in any particular cycle. Because a journalist called me 8 days before the last election and asked me about my writings on cycles of deregulation and re-regulation. And he asked if we were about to enter a deregulatory moment in which Congress would enact sweeping repeals of financial reforms. And I said, no, that's just not possible, right? Like, it's just too soon to the financial crisis. So don't ask scholars to make political predictions. What explains the pattern? I'm not going to tell you, buy my book, $140 in hard copy. It's here in the Hastings Law Library. The vanity in me made me look it up. There's a couple notable exceptions I should note, right? So one exception is the Jobs Act, which actually came pretty soon after the financial crisis. What explains why that happened? Well, I think if we look at the political climate in America when the Jobs Act was being pushed through pretty quickly, we had taken fiscal policy off the table when stimulus became a dirty word, and monetary policy was largely rendered ineffective as central banks really can't cut interest rates below zero. It's not unprecedented. In Japan, the Japanese parliament loosened some banking regulations as they confronted a very deep recession after the real estate bubble popped at the end of the 1980s. The bad news is that we might be going back to a period in which the US and England were in the 19th century when we had financial crises roughly every 10 years. And financial stability can create political instability. So ask yourselves whether we would be in the current political moment that we were had the financial crisis not been as bad as it was 10 years ago. So at some point the political winds will change. So I want to leave with a few lessons for the next policymakers who are drafting the next regulations. And I'll leave it to you to figure out what regulations you favor and what you don't. One is that we ought to think about regulations in terms of engineering interest group competition. So one of the important but underappreciated aspects of Glass-Steagall was how it created interest group competition, at least for a little while. So we were talking a little bit at lunch about how there were pitched litigation battles in the DC circuit in the 1980s as investment banks sought to keep commercial banks out of the securities industry. Can we go back? Very big question. There's also a puzzle that we also talked about at lunch, which is why are community banks so aligned with the big financial conglomerates in recent regulatory debates? I want to veer off topic. I know my time is short, so I'll hurry. But I want to tease out a recurring theme that we started to hear in the opening keynote speech and in the opening panels. And that is that it's more of a warning to progressives or to conservatives that some of your positions on administrative law mechanisms and administrative law devices can be turned against you when the presidential or congressional winds turn, right? So you mentioned the CFPB. The CFPB was designed with a single director rather than a multi-member commission. Why was it done that way? To enable quick and pretty decisive regulatory reforms without getting bogged down the way the SEC is with 2 Democrats, 2 Republicans, and a chair picked by the president. It doesn't look so great now, right, if you have Mick Mulvaney as the CFPB director and you're in favor of consumer financial protection. Similarly, the FSOC, the Financial Stability Oversight Council, centralized reform, and it created enormous potential for coordinating reforms. But to go back to Professor Light's point from this morning, the FSOC, as centralizing regulatory reform powers, is potentially now a vehicle for centralizing deregulation and fighting the kind of horizontal horcruxes that you were talking about. Also, federalism kind of cuts both ways, right? So we've heard a little bit about marijuana regulation. Federalism in consumer financial protection or state regulation is favored by consumer protection. It's not favored by large financial conglomerates. So I think if we go back to Professor Price's opening remarks, be careful in thinking about your preferences or your administrative law agenda, because at some point the winds will change. So thank you, and apologize if I went over time.
Next is Gaurav Vasisht from the Volcker Alliance.
Let's shut this. Close this down. All right, thank you to John Crawford and UC Hastings for inviting me to speak here today. It's a privilege to be here, and I should say that my remarks are my own and not the beliefs of anyone else within the Volcker Alliance. So I thought today I would focus my attention on the ongoing review of the Treasury Department of financial regulation under an executive order that President Trump issued in February of this year. And the executive order basically directed the Treasury Department to undertake a very broad review of all financial laws, rules, regulations, guidances, et cetera, and identify those that were inconsistent with some core beliefs that President Trump articulated in the executive order, and make recommendations to bring them within those core beliefs. And so far, the Treasury Department has issued 3 reports, and if you add up all of the recommendations that have been made, it comes out to roughly between 300 and 400 recommendations. So John talked a little bit about death by 1,000 cuts. I think we're going to be approaching 1,000 recommendations pretty soon by the time the other 3 reports are issued. But my view on the topic is that 7 years following the passage of Dodd-Frank, I think it's appropriate and I think it's advisable to review the experience that we've had under the post-crisis reform package. But for the review to be successful, it really has to adhere to some core principles of its own. The President Trump's executive order talks about core principles, but the review process itself must have some core principles if it's going to be successful. So first, I would say that the review shouldn't be tethered to unsubstantiated claims that the law has somehow dampened economic growth or reduced market liquidity. The narrative is just not supported by data. It's really a political argument to justify the review in the first place. I think policymakers should really be liberated from this claim, because it puts a lot of political pressure to come up with things that unleash, quote unquote, the American economy. And I don't think that that's really the focus. I think our focus should be sustainable economic growth, and I think should be smart about it. And I think if you take away that component, I think policymakers and regulators and others can be, a little bit more sober about what they're proposing. And I think in this case, they would probably be proposing more, ways of simplifying and streamlining regulation. Second, the review should recognize that a resilient financial system capable of withstanding a major financial shock is critical to sustainable economic growth. A strong financial system can mitigate the effects of a downturn on lending. A weak financial system, by contrast, can put the welfare of citizens and taxpayers at risk, as we saw in the last financial crisis. Third, the review should remain mindful of the historical context, and this is, Erik's written a book about this. But put simply, we've been here before, and we have a terrible track record of weakening regulation at precisely the wrong time. Things are going well, we tend to roll back, and it sets us up for trouble when times turn. As the FDIC chairman, Marty Gruenberg, said just a couple of days ago in a speech at Brookings, history shows that the seeds of banking crises are sown by the decisions banks and bank policymakers make when they have maximum confidence that the horizon is clear. And I think we should aim to avoid making this mistake if we can, and instead do the opposite. We should prepare for bad times during the good times. So judged against these three core principles, I think the Trump Treasury Review falls short. One, it focuses too much on unleashing economic growth. Two, it neglects the historical context. And while some of its suggestions may actually be pretty good in terms of community banks, the bulk of its major recommendations undermine the core pillars of Dodd-Frank as they relate to the largest financial institutions. So under the Treasury proposal, fewer large banks would be the subject of enhanced prudential standards. Those standards themselves would be weakened. Something called the supplementary leverage ratio would be diluted. Stress testing would be reduced in frequency and effectuated through notice and comment, which would basically kill the exercise. Somebody made the analogy that the stress test would become a take-home exam. You're basically just like, handing over the model, you're giving it to them, and then they can. So that's not smart. Banks would have greater opportunity to engage in risky proprietary trading. Important reforms related to securitization would be rolled back. Oddly, the FDIC, the agency that's charged to resolve systemic financial institutions, is strangely taken out of the resolution planning process. Now, can you imagine you're going to come to the scene and resolve a financial institution in a sort of a heroic way, but you're not part of the preparation. And there's no real explanation for it. It seems kind of strange to me. My fear is that there's a report that's coming that hasn't been issued that's specific to OLA, which is Title II, and I'm fearful that they're showing us what they might do by taking the FDIC out of this process now. I may be wrong on that, but it's kind of peculiar, the change they've made or recommending. The future of OLA and the FSOC, both of which are critically important to mitigating systemic risk, remains in question. So these are all things that are really bad, but of course they beg the question, what should we be doing instead, if not this? And I would suggest that the first thing we should do is reorganize our regulatory system. It's highly fragmented, it's outdated, it's developed over a long period of time, largely a response to prior crises. It has large gaps, overlaps, all sorts of gaps and boundaries, problems, inefficiencies. It increases systemic risk. It puts imposes a lot of regulatory burdens on regulated institutions. It prevents us from gaining a full understanding of the financial markets, the treasury markets, which are so important. There are really significant gaps in our understanding of the treasury markets, which is pretty remarkable when you think about it. We don't fully understand derivatives. We don't fully understand short-term funding, and many other things. It impedes systemic risk regulation. And in the report that Treasury has issued, all three reports, they acknowledge some of these problems. They say that the regulatory structure is bad, but they don't demonstrate enough leadership to actually come up with a proposal to fix the problem. Hank Paulson had a proposal to fix it in 2008. Paul Volckers had a proposal to fix the system. But in this Treasury report, they recommend, they actually spend a fair bit of time talking about why the SEC and CFTC should not be merged. And they propose what I think is a Band-Aid solution for assigning lead regulators whenever there's a complex rulemaking. So my fear is that over time you'll assign a whole bunch of lead regulators, and the system's going to become even more complex than it is, and that would be a really silly outcome, because if you're trying to make the system simpler by assigning lead regulators, you'll in the long run make it. But another thought I have is banks are beginning to complain that we need a lead regulator. My sense is that if they're doing that, then they should really be lobbying for more comprehensive structural reform, and not going to their favorite regulator and saying, hey, you be my lead regulator on this issue. That's be a really silly outcome if that were to take place. So the first thing we should do is reorganize our regulatory system. The second thing I think we need to understand is we need to strengthen capital requirements instead of weakening them. Large banks need to be able to withstand shocks. They need lots of loss-absorbing capital. My view is that we need both a supplementary leverage ratio as well as risk-based capital, because both have weaknesses that the other makes up for. Number three, we should renew our focus in the short-term wholesale funding markets. We used to talk a lot about this. I think we've stopped talking about it, but the center of the financial crisis, the core of instability was in these markets, repos, asset-backed commercial paper, these types of things. And we should also renew our focus on the participants that engage in these markets, the money market funds. We should also be looking at broker-dealers. We should monitor some of the largest, most leveraged hedge funds as well. And this was in a paper that John Crawford wrote, both of those. So I would focus on that. I would also focus on narrowing the bankruptcy safe harbors, which were a major reason for runs and fire sales during the last crisis. Number four, we should strengthen the financial market infrastructure, particularly clearinghouses for OTC derivatives. And I'm going to leave it up to Colleen to talk about the technical aspects of all of that, which Colleen's written a very comprehensive paper on the issue, and it's an excellent read for those who are interested. And finally, I think we've got work to do on the GSE reform front. It's a politically difficult issue and largely neglected, but perhaps we need to devote some more attention there. So these proposals, I think, would make the financial system safer, and I think would support more sustainable economic growth. By contrast, I think the Treasury review, which has made almost 400 recommendations so far, would weaken the system and set us up for future trouble. I'd also like to add that there's been some more recent activity in Congress. Senator Crapo has been able to reach a deal with some of the moderate Democrats, and I think what they've come up with is a very good, it's a very modest financial reform package, but it's a good package. But I would still recommend just a few changes. If I could have recommended these changes, I would have. But I figured I'd talk about them anyway. The legislation would raise the threshold for what is a systemically important bank from 50 billion to 250 billion, which is a 5-fold increase. And so the banks that are currently, the banks that are above $50 billion get regulated in a more stringent, under enhanced prudential standards. Well, now, under this legislation, that number would go from 50 to 250 billion. So I wouldn't raise it 5-fold. I'd probably raise it, but it wouldn't be that much in my mind. I think if you raise it by that much, too many large banks might receive a pass in the process that should be regulated under more stringent requirements. The legislation also makes a change to the supplementary leverage ratio as it pertains to custodial banks. I wouldn't make that change. My fear is, and this is a fear that I have with changes to the leverage ratio anyway, there's a ratio, you have a denominator, the denominator is total assets, and they're looking for things to take out of the denominator from total assets so that, once you start taking things out, the capital requirements become weaker. And my fear is that once you take one thing out, then there's intense lobbying, and then next year they're back again, and then again, and eventually you wind up with a really sort of gutted, requirement. So I think it just sort of, it might open the floodgates, so I wouldn't make that change. And finally, the legislation assigns the task of studying algorithmic trading to the SEC. I wouldn't give that assignment to the SEC. I would give it to either the Treasury or the Fed and have them do an interagency exercise and bring in the SEC, bring in the CFTC, bring in other agencies. But giving it to just the SEC, when the SEC, it's not even clear they have a financial stability mandate. They care about market integrity and investor protection and things like that. But there might be some from stability components, and there's a lot of this activity taking place in the Treasury market. So I think you need a regulator with a sort of a broader view. You need a regulator that has a stability mandate. So I would give it to either the Treasury or the Fed. The funniest thing to me is that we have just going back to the regulatory system, we have the SEC, which has a mandate for investor protection and market integrity and has reach into the asset management industry and some of these other areas. The Federal Reserve has a mandate for financial stability, but doesn't have the reach into these areas. So you have a financial stability, macroprudential regulator that can study these areas but can't do anything about it. And then you have another regulator that has reach into these areas but doesn't have a stability mandate. So you can, if there's a next crisis, if there's trouble in this area, you can imagine that there's a Senate Banking Committee asking questions of the heads of these agencies. Well, who should be held accountable? And you'll see them go like this. And that's a pretty lousy outcome. So it again sort of goes back to the regulatory structure. But in terms of this legislation, I would make those three changes. But even if they're not made, I still think that this is a really good outcome. So those are some thoughts, and I'd love to hear other viewpoints. Thank you.
Thanks, Gaurav. And next up is Colleen Baker, and let me try to help you.
Right there. Okay. Thank you.
Okay, it's Friday afternoon, and I feel a bit like Erin did talking about ERISA. I'm going to talk about clearinghouses for over-the-counter derivatives. I'm going to assume that there's probably a limited knowledge in the audience, so I'm going to sort of first take us through clearinghouses and talk about why this is an area of financial markets where the deregulatory trend is actually being not debunked, but bucking the trend, going in the other direction. And I certainly agree with the remarks that have come before me. So I want to thank John for the invitation to speak and all the conference organizers and, of course, UC Hastings Law School. So why am I going to focus on over-the-counter derivative markets and their clearinghouses? So there we go. Just very quickly, the over-the-counter derivative markets are the biggest financial markets in the world. Most of it is made up of interest rate derivatives, then foreign exchange derivatives, and then you have smaller categories such as the credit derivatives. Probably a lot of people at least have heard of the infamous credit default swaps that caused a little bit of trouble here and there in the financial crisis. So just as a really quick reminder, let's see, can I get it all on one, or you just get a sneak preview of what's to come?
PDF, so.
It's the PDF. Okay, perfect. Yeah. Thanks, John. So just a brief reminder, during the financial crisis in September of 2008, American International Group had basically insured Credit derivatives, credit default swaps are similar to an insurance policy in that the credit protection seller, in this case AIG, is saying, look, we will pay you if some sort of debt obligation goes down in value. And the credit protection buyer is like all of us who buy insurance for our homes, cars, etc. We pay some amount of money so that if there's some sort of trouble, that we can get paid from the company. Now, there are two really interesting things about credit default swaps in this whole area. One, even though they are functionally equivalent in many ways to insurance, they're not regulated like insurance. Insurance is heavily regulated by the states, and that includes set-asides of money so that companies actually have the money to pay should they need to make these payouts. That was not the case in this land pre-Dodd-Frank. The other difference is with credit default swaps, you don't actually have to have an insurable interest in the debt or the underlying credit obligation. In other words, I can't buy insurance on John's house, and if John's house burns down, I get paid off. But actually, in the financial markets with credit derivatives, you could do something similar to that. You don't need an insurable interest. So long story short, AIG had sold about $500 billion. Yes, that's $500 billion of credit protection on credit default swaps. And so between that, not putting aside monies, and also their securities lending activity, the U.S. government eventually stepped in with over $180 billion of support. I think this is startling when you think about countries such as Argentina going bankrupt because of a mere $80 billion. And this is one country, right? So, all right. Policymakers around the world under the auspices of the G20 said never again. We can't let this happen again. The over-the-counter derivative markets were not heavily regulated before the financial crisis. Regulators were not aware of the positions, all the exposure that AIG had built up. They were being regulated by the Office of Thrift Supervision, which is now defunct. Compliments of Dodd-Frank. And this was also a subsidiary of AIG over in the UK. So the G20 came up with a framework of reforms for financial markets in general, and that included the derivative markets. And I sort of have these reforms in a nutshell. I would argue that the centerpiece of these reforms was the mandate that over-the-counter derivatives use clearinghouses. So now I'm going to talk about why that would be and why policymakers saw this as a cure to the woes that had gone on with AIG. So bear with me. We're going to run through the basics of a clearinghouse. So before the financial crisis, you had financial market participants such as Morgan Stanley, Goldman Sachs, JP Morgan Chase. They had all of these derivative contracts traded amongst each other. Regulators had no transparency into the market. Financial market players did not know who their counterparties had other exposures to. So how one could really judge what the credit risk of the counterparty was, well, that was sort of an open question to anyone. So this, again, is pre-Dodd-Frank world. Let's imagine A is Goldman Sachs, who buys credit protection from B, JP Morgan Chase. So here we have the buyer, here we have the seller, okay? How does a clearinghouse change all of this? Well, the clearinghouse essentially gets into the middle of the trade. And what do I mean by that? Well, legally, the original trade is novated, and we get two new contractual relationships. I had said that A, Goldman Sachs was the buyer, Goldman Sachs is still the buyer, but now the seller is the clearinghouse. B, JP Morgan Chase is still a seller, but now the clearinghouse is essentially the buyer, so you have two mirror trades. So this does a number of things. It increases transparency in these markets. There's a lot of transactional efficiencies because these institutions now become what are called clearing members. So now the JP Morgans, Goldman Sachs's of the world, they're all clearing members. It's like a club of members who have to pass certain financial standards to be able to become what's called a clearing member, because they need to have a lot of capital and financial strength to make sure that they can make these payments. And the clearinghouse can also net payments. But most importantly, and I think what a lot of people don't understand, is the clearinghouse is not just doing a pass-through. In other words, if JP Morgan Chase does not make good on a payment to the clearinghouse can't turn to Goldman Sachs and say, look, we're really sorry, but we didn't get paid, and so we don't have the money to pay you. No, the clearinghouse has a legal obligation to make its payments regardless of whether it gets the payments it is owed. And we're talking here about billions in payments on very small time frames. So in one sense, there is quite an improvement in transactional efficiency, increased transparency, but you have to make sure that the clearinghouse has a lot of talent in terms of credit risk management. And in fact, historically they have. Clearinghouses have failed in the past, but it has been rare. On the whole, they have performed very well. And you might ask yourself, well, why have they performed so well? And I should say that it's the private markets that developed this, what some economists would say is a contractual device to ensure contractual performance. So why are they so strong? Why are they so robust in terms of having the money to pay out on contracts, even if they don't receive the payments they should have? And I should add, too, that in the over-the-counter derivative markets world, making sure that your counterparty actually can make the payments that they have contractually obligated themselves to do is very important, because these contracts tend to last for many years, 5 years, 10 years. Whereas in the securities world, that transaction is usually finalized. In other words, contractual obligations between the parties are usually over within 3 days. So you're looking at a very short time frame in a traditional securities world. Here you're looking at years. So you want to make sure that you're actually going to be paid. Okay, so back to how do clearinghouses make sure that they're going to have the financial strength and wherewithal, the resilience to pay? Well, they have several layers of credit risk management. One, I mentioned that clearing members have to meet very stringent financial requirements. All the clearing members have to give what's called initial margin. It's like insurance set-asides that, if we default, we'll have the money there to pay. All of the clearing members have to make contributions to a common pool default fund. So in other words, in sum, there are several layers of risk management here to ensure that even if one of the clearing members does not pay on their contractual obligations, given that that doesn't give the clearinghouse an out from making the payments it owes, that the monies will be there to make those payments. Now, for several years, this was looked upon as a great solution, and it still has, I think, a lot of virtues. But where we are right now, and why I say this is bucking the deregulatory trend, is that I think that policymakers across the spectrum have realized that, well, we might hit here, and here is called the end of the waterfall. In other words, people are now realizing, oh, wait, if we have a systemic crisis, in other words, more than one or two banks getting into trouble, it could be the case that even though we have all these layers of risk management, it's not going to be enough. And what are we going to do then? So in this world where I'm very focused right now, essentially the financial market plumbing, the policy discussions around the world, not just in the US, are, okay, what do we do if we get to the end of the waterfall? And the answer to that question is really pretty important, because now that we have, you remember that picture where everything has been centralized around the clearinghouses, you can just get a picture. I know this is, you probably can't read that from back here, but here are some of the most important clearinghouses. And we're just talking about a handful around the world. Intercontinental Exchange here, the Chicago Mercantile Exchange, Schwartz Clear, that's in London. And you have all the really big important banks, JP Morgan Chase, Morgan Stanley, UBS, Goldman Sachs, et cetera. So now they're all interconnected in a network such that if you ever thought one of them was too big to fail, you can imagine about the status of these clearinghouses. So in the past couple of years, it has increasingly become more common, as I've mentioned, for people to realize, okay, these clearinghouses have a lot of great virtues, but we also have to figure out what we're going to do if and when one of them gets in trouble. So even back into 2014, you saw policymakers saying these things have become so important post-Dodd-Frank that they must always operate, period, end of story. That a disruption, not acceptable, even in extreme circumstances, they've got to function. And these are policymakers. This is not, the big banks. And then you see even, and here comes where it's bucking the deregulatory trend. You see just earlier this month, the president of the Federal Reserve Bank of New York saying that, and these are quotes, that work needed to ensure that CCPs, that's acronym for clearinghouses, can always recover and hasn't yet been completed. This is an issue of increased importance. And then one of the Treasury reports that Gaurav was talking about in October said, and I'm bolding these, this is my italics, that Treasury recommends improved oversight and that regulators must finalize, well, what are we going to do with one of these institutions if they get into trouble? Because that's right now the $64 million question. I don't think anyone really knows the answer. So I've written a lot about clearinghouses, as Gaurav mentioned, and in my current research, I'm really focused on what I think is a shortfall in these international discussions about what are we going to do if a clearinghouse gets into trouble. Well, they're not talking about clearinghouse ownership. And why do I think that important? Well, because clearinghouses, some of them are member-owned institutions. In other words, they are owned by the people who are actually using them. But some clearinghouses are publicly traded institutions that are really increasingly looking towards clearing as a revenue center, okay? And so we're calling these financial market utilities, but that is in some cases quite a misnomer because they're really not they're not being regulated as utilities, and they're certainly not traditional utilities in any sense in which I'm aware of. And my concern is that unless we focus on the ownership issue, that it's going to be much harder to coordinate a recovery or a resolution of one of these institutions because with the member-owned clearinghouses, both the clearing members and the owners of the clearinghouses, their economic incentives are aligned. With the clearinghouses, where you have the clearing members taking on the risk of any defaults happening and having to put in the money, they are essentially bearing the risk in those institutions. But in those institutions, it's the shareholders, a different set of stakeholders that are benefiting from the profits. As scholars have pointed out, and as I agree with, that's a serious misalignment of incentives there. And so I think you have to think about that and how it might contribute to how such an organization is run, but ultimately how well recovery and resolution efforts could potentially be coordinated in a time of crisis. So my recommendation would be that our recovery and resolution efforts take two different paths depending upon ownership structure. And I'll go ahead and admit that I think member-owned institutions that look more like traditional utilities is the path to go and is the path to much more likely minimize any sort of assistance from governments around the world. So I would design those paths to incentivize a movement towards a true utility structure. Thank you.
Thank you, Colleen. Next, our final speaker is David Zaring to talk about de-designation.
Okay, well, thank you, John. It's a pleasure to be here. And, you know, cognizant of my role as the last speaker, I really wanted to get you with something grabby. And so I thought I'd start with the title slide, the de-designation of systemically important non-bank institutions. It really rolls off the tongue. And what I'm going to do in this talk is talk to you about, I'm going to try to answer, I'm going to talk about three things. First of all, I'm going to talk about the debate over the designation of these very large, for the most part, insurance companies as systemically significant and therefore subject to extra regulatory oversight. Then I'm going to talk about the structure of the Financial Stability Oversight Council, which was an innovation in Dodd-Frank and which created this mechanism for the designation of these institutions, a mechanism that is currently being revisited by the Treasury Department in a report issued today, which I'll also talk about. And finally, I'll talk about the way that de-designation has happened. So shortly after the financial crisis, three insurance companies and one sort of more general lender, commercial lender, were designated as systemically significant. And now only one of those institutions remains designated. Two of them were de-designated by the Financial Stability Oversight Council itself, and one as good as de-designated by a court. And I want to compare the regulatory process between agency and court and see what sort of insights we can get. Okay, so that's the plan. There's the story, and the story is basically that the prospect that non-banks could be designated as systemically significant and subjected to oversight was something that terrified a number of very large financial companies. And so we can see that two firms, GE Capital and AIG, as I'll show you, transformed themselves once designated as systemically significant. And one firm successfully sued to avoid the designation process. And you can see some of the way that the de-designation happened in this slide here, which shows how GE changed its asset makeup, the amount of money it held in cash, the amount of money, the way it held its assets and liabilities in commercial paper and runnable deposits. And the overall vibe is that the firm really transformed itself in order to avoid designation more generally. It, along with three insurance companies and, as Colleen was discussing, 8 financial market utilities were ultimately designated by the council as systemically significant and subject to extra supervision. And I've written in the past, along with my colleague Dan Schwartz at Minnesota, that there are some reasons to think that this sort of regulatory process is a good idea. One reason it might be a good idea is because finance is mysterious and the sources of financial risk are mysterious. And so it might be good to have some sort of scary tool with which to suggest firmly to non-bank financial institutions that they shouldn't try to seek out systemic risk and take advantage of riskless or risky business activities with some sense that a bailout might be waiting if those risks went bad. And finally, the designation process didn't just discipline non-bank firms, it also disciplined regulators who were failing to regulate their industry to a degree that the Financial Stability Oversight Council thought appropriate. Okay, so those are some advantages, and that's not the only advantage. If you're regulating the insurance industry by looking very closely at 3 insurance companies, that's a very efficient way to do something about risky insurance practices. And we can see that FSOC regulation has met with a great deal of changed conduct. So for example, the insurance industry itself it got way out of risky assets and has done since the threat of FSOC designation was created. Okay, on the other hand, you can also see why you might want to create a regulatory process which singles out a firm. And an example of that is the unique way that AIG, as opposed to other insurance companies, failed during the financial crisis. Essentially, AIG was up to two kinds of mischief. In one, it was writing credit default swaps in an unhedged way to any financial institution that cared to enter the trade with it. And then secondly, it was engaged in securities lending, which meant that basically it was loaning out its securities in exchange for cash. The problem was that when the financial crisis hit, it looked like it would have to pay the insurance that it wrote on its credit default swaps. And at the same time, its securities lending funding dried up because many of the people who were borrowing the securities were the kinds of financial institutions that got into trouble during the crisis. So put those two problems together, and all of a sudden you have a massive insurance company on the verge of collapse. And an insurance company that if regulators were taking a close look at and insisting on extra regulatory protections, might have been less likely to run into that kind of trouble. Nonetheless, designation has been super controversial. And you can see the various people or actors who have weighed in on this issue up on this slide here. The chair of the Senate Banking Committee wondered whether the council's designations are, quote, sufficiently open, objective, data-driven, and free from the influence of outside organizations. That's a way of saying foreign regulators. The House went one better and voted this year to rescind the power of the council to designate financial institutions as systemically significant. And as I'll talk about in a little bit, a court also found that the designation decision made in the case of MetLife was arbitrary and capricious. All of this was animated by an idea that, as the American Action Forum put in the sort of like graphic that I show for you there, that the designation process was a Hotel California, that you'd never be able to leave once designated. And that's something that I think, by the way, current events have suggested wasn't really going to be the case. The debate goes further than that. There's been a sense that, on the one hand, Jeremy Kress at the University of Michigan has said that the designation process is flexible and allows, if focused on entities, it allows regulators to look at firms closely and take actions to respond to problems created by those firms in a sort of nuanced way. But Christina Skinner has written that there ought to be sort of a variable level of designation, that the binary nature of get killed by FSOC or don't worry is actually an under-nuanced sort of form of regulation. It looks a little bit like the Department of Agriculture's, we either shut down the meat processing plant and throw everyone out of work, or we don't do anything. And so she's proposed some sort of gradated oversight and information gathering intermediate step that she calls SIFI Light. And the Treasury Department itself has said that it wants to take a different approach to financial non-bank risky activities. And it announced this in this report that it issued this morning. And some of the upshots of the report is, first of all, that it's going to essentially turn the council into something of a think tank. And the think tank would say these activities that are risky should be identified, and regulators should regulate activities, not firms. So the idea is the council wouldn't do any designating itself, but it would tell its members, go out there and take a close look at everybody who's writing credit default swaps. It's also said that if there is any sort of designation, that there ought to be a cost-benefit analysis that accompanies the designation. A controversial claim because of the difficulty with assessing the benefits of a regulation designed to avoid a financial crisis, which are extremely hard to forecast. How many people lose their jobs and how bad is the economy hurt? Those cost-benefit analyses are controversial. Okay, so that was part one of my talk. In my remaining 2 minutes, I'll move on to part 2 and 3. Okay, so this is the institution, and that's a little bit about the controversy. Or that's a little bit about the controversy and, an overview of the regulatory intervention that's being created controversy. How does the council work? I mean, one of the things that's interesting about it is it's a group of agencies. It's a regulator made up of regulators without much regulatory power in itself. It's chaired by the Treasury Department, and it includes all of the myriad American federal financial regulators, of whom there are, it is thought by many in the academy and elsewhere, too many. And it also includes some non-federal regulators and some federal regulators who just do research, like the Office of Financial Research that's in the Department of the Treasury. But the council also has a seat for a state banking regulator, a state insurance commissioner, and a state securities commissioner. And the idea is that these people will get together, only federal regulators get to vote on designation processes, and interpret guidance from Congress, which is extraordinarily broad. It's the old multi-factor test, as Justice Scalia said. The Dodd-Frank Wall Street Reform Act includes all of these factors, which FSOC has interpreted, that it should apply to deciding whether institutions or activities are systemically risky. And the final factor is any other risk-related factors that the council deems appropriate. So quite a broad mandate to do whatever it wants. And the council tried to give the non-bank financial industry some guidance as to about what that meant by saying it was going to focus on size, substitutability, and interconnectedness, leverage, liquidity, and existing regulatory scrutiny. So those 6 factors were how it distilled congressional's guidance, and it distilled it in a 3-part test. And so the first test was supposed to be quantitative and simple. The question was, how big are you? And if you're big enough, then you could be designated. And then there would be followed by 2 qualitative steps, one in which the council and its regulators themselves think about the riskiness of a particular institution, and a 3rd step where the institution can come in and tell the council and its regulators that it shouldn't be designated and present evidence in its defense. So the stage 1 thresholds, and this is one of the things that Treasury would like to change, as I think some of Colleen and Gaurav talked about, as 50 billion or more in assets meant that you were subject to investigation by the council. And for non-banks, the Treasury Department has suggested that number should be increased to 250 billion. And then in stage 3, there's this process of interactive back and forth, followed by an ultimate council decision, which would be written, and that's how the designation decision would be made. Okay, so that's the process and makeup of the council. The final thing I wanted to talk about was the way that de-designation has happened. And so I wanted to reproduce to you the 2 council parts, very small parts, of the 2 council de-designations, and contrast it to the reasons why a court decided that the designation of MetLife was arbitrary and capricious. So I'm pulling from the introduction of the council's decision to de-designate GE Capital on June 28th, 2016. And basically the council said, look, GE Capital has fundamentally changed its business through a series of divestitures, a transforming of the funding model, a corporate reorganization, decreased its total assets by 50%, shifted away from short-term funding. The idea about short-term funding is that if you depend to make payroll and meet your obligations on funding which could expire within a year, then anytime within that year, that funding could dry up and then you'll be in a pickle. And has sold off its depository institution. So there you go, a bunch of reasons why GE got smaller, less interconnected, and less risky, and therefore subject to de-designation. For AIG, the council just kind of came up with what I think it thinks of as a killer chart. And it said, let's look at AIG today, and let's look at how it fits with the sort of largest financial companies in the country. It's much smaller than the biggest banks. It's smaller even as a matter of total assets than an undesignated insurance company, that's Berkshire Hathaway, and substantially smaller than the other 2 designated insurance companies, Prudential and MetLife. In addition, as you can see, it doesn't do much securities lending. That's the 4.1 number over here. There aren't a lot of credit default swaps written on AIG, and its leverage, that is, how many total assets it has to sort of equity, is relatively low compared to its peer institutions. So there you go. The council said, look, the new AIG isn't as leveraged as banks and insurance companies. It's gotten smaller, and it's not the subject of a lot of credit protection contracts. It's good enough for us for de-designation, and that was why the decision was made. Okay, so compare that to the MetLife successful effort to block its designation in court, where the court made a sort of standard sort of administrative procedural account of why MetLife had failed to, why the council had failed to adequately explain why MetLife was a systemically risky institution. And the idea is that the court itself doesn't know the answer to that question, what makes an institution systemically risky. But during the designation process, 2 of FSOC's definitions were ignored or at least abandoned. Though an agency can change its mind, FSOC maintains that it changed nothing, and the court thought that FSOC was lying. In addition, the court made an incredibly strained argument that the council had to do a cost-benefit analysis before designating a firm like MetLife, and the council had refused to do a quantitative cost-benefit analysis. And because it did not do one, that was an independent basis for reversing its designation. So I don't have, and in fact, I'd be interested in hearing if there's sort of more insightful things to say about this. But I think what you see with deregulatory courts and a deregulatory council is the standard distinction between substance and procedure in administrative law. FSOC looked at how big the institutions were or had become, how seriously they had taken the effort to become less risky, and how interconnected the institution was once it was shrunken. Was there a chance that if this institution went belly up, the institutions that did business with it would be at risk for going belly up as well? That's the thing you worry about most in a financial crisis, because that's how finance is different from, say, auto manufacturing, where just because Chrysler goes bankrupt doesn't mean that Ford and GM will as well. You can't say the same thing necessarily, as we saw in the last crisis, about, say, investment banks. So that's FSOC's reasoning, but the court's reasoning was basically what I would characterize as traditional focus on procedure and maybe court-based second-guessing about the procedures used by the council to make its designation. And I think you can see that those are 2 different approaches to deregulation. One focuses on the riskiness of financial institutions, the other focuses on a decision-making process that went into that riskiness determination. And so with that, I will look forward to either a happy hour or your questions. I'm not sure what
or both. Thank you, David. So, Dorit, there's going to be a reception after this, right? Is it in the same place where we had lunch?
The reception will be here.
Oh, here.
And it will be starting at 5, so in between we'll have a short break.
Okay. If I think we can open the floor to questions, and since a happy hour awaits, people can leave if they get bored, including the panelists. But I'll stay here as long as anyone has questions. So, any questions?
Can I ask a question for David, or am I going to be unpopular?
No, actually, Erik had asked me to reserve time for rebuttal after David spoke, so he should go. Feel free to go ahead.
So, David, I'm wondering whether there's a little bit of a silver lining in the de-designation process, whether it's in the courts or in the agencies, because one of the things that we heard when Dodd-Frank was passed, that it was the end of due process as we know it. So if the courts are actually able to de-designate or effectively de-designate MetLife, or if FSOC is willing to go in the other direction, isn't that sort of puncturing that balloon?
Yeah, I definitely think so, because FSOC has made very clear that this is no Hotel California, and in fact was a quite conservatively applied designation tool. You know, only four non-banks and 8 financial market utilities. That is just not exactly promiscuous over-regulation. I think it's fair to say that the council itself didn't view designation as something that shouldn't be revisited, and that's good. And then I'm less happy about the court's intervention than you are, but it's, you know, it's certainly the case that judicial review of these decisions are appropriate. I thought that the council provided plenty of basis for its designation of MetLife. But we'll see. So that case is being appealed, and so far the Trump administration has not dropped the appeal. You know, one of the ways they could keep MetLife undesignated is just drop the appeal, in which case the designation would be arbitrary and MetLife would be free to go. But the D.C. Circuit has heard arguments, is still hanging around waiting. I think it's been under submission for about a year. And so far, there's been no move by the Justice Department or the Treasury Department to drop the appeal. So we'll see what happens.
It is 4:45. And with that, unless you can come up if you have other questions that you're too embarrassed to ask everyone. But thank you very much.